9 years old and I'm a young carer. And I like horses.
I'm Matt, I'm 17, I'm an engineering apprentice. Been a young carer for about 7 years, since I was 10. I care for my brother. A young carer is a person that is more than just a caring family member. They go out of the way to help and support their family in ways that an adult might do. Try and teach him some skills, like he can't read a clock properly. Yeah, teach him that, help him, ask him what his troubles are. And some of my roles have been extended to my mum now. She's not very well, and my grandma.
My older brother usually is rather angry at his games or us, and usually what he does is he runs, makes silly noises around the house and gets angry and bangs.
He used to get quite angry and quite violent at times. It's a bit of a standoff really. You've got to figure out what to do to make sure nothing bad happens really.
Jasmine is very good at being mindful about things that might upset her brother.
If he's on the step, I'll try not to go up the stairs so I don't go near him, to give him space. Even if I'm desperate for the toilet, I just have to hold it sometimes. And if he's angry and my other brother's trying to annoy him, I'll tell him just don't bother. If whoever you're young caring for, if they're angry, then I'll just say give them space and give them time to calm down. And that's it. Sometimes if it gets out of hand, I'd rather go to my next door neighbour's house or in my dad's shed with him.
Removing yourself makes you feel like you're sort of useless in a way because you're not there to do anything. But then you realise that otherwise you could make it worse. And I have done in several situations where if you stand there and you keep on provoking it or making it worse, it just makes life harder for yourself. It sounds strange, but removing yourself from a situation is probably the best thing you can do because you're not causing any further harm, you're just taking yourself away. When I remove myself, music is sort of the best thing, or something to distract myself. Put on a video game, watch a film, removing myself not only from the situation but from the atmosphere as well.
I do a thing called Elsa and I go out with the girl and then I do stuff to help me control my anger and how I can help other people.
I have mentioned that I am a young carer to college, but I'm not sure I've really explained to him what that means or what responsibilities that holds really. Many people who are young carers don't see themselves as young carers, they just see themselves as just a caring family member. Obviously people have different experiences at home, different caring responsibilities, but I think sharing a lot can help different situations as you're getting maybe different methods to calm it down, or maybe something else to do to calm yourself down as well. Made me feel like maybe I wasn't by myself. I think the most difficult part of living with a sibling that needs support is you realising that you are not being neglected, it's just that they need more support than an average young person. I am proud to be a young carer. I hope I've made my brother's life a bit easier. May not see it, may not know that I've tried, but it doesn't matter as long as I can see that he's doing the best he can do and I'm helping him with it. I think that's the best thing that I've done for my brother, yeah.
Wow, such mature young people. Fantastic, and we know there are hundreds, if not thousands, of young people out there acting as being carers for members of their family. Okay. Can I move to the report of the Chief Exec?
Chair, thank you very much. I just want to put a couple of people on warning. Simon, I'm going to ask you to talk to the right care, right person piece, because you do it so much better than me, and a piece that's not within the report. But John, I think you should give the board just some high-level feedback on what's been happening at Arrow Park this week, because I think that's materially important. But before I do that, there's a few things I want to mention. Without making too much fuss about it, because I know neither of the individuals would like it, but I do just want to place on record my thanks to Chris Samosa and Claire Wilson. This, for each of them, will be their last meeting today. I thank them not only for their service to the ICB, but to the wider NHS. Both will be sorely missed. And the report just details the fact that we will have Mike Gibney joining us as Chief People Officer in January, and Mark Bakewell, who's hiding at the back of the room today, will be taking on the role of Chief Finance Officer for an interim period for us. So really, really important that we acknowledge that, but I know there will be plenty of opportunities to pay our thanks and tributes to those individuals leaving us, and I won't say any more here today. I also just want to note within the document, the paragraph that I've put in about the Secretary of State's visit to the patch, where he came and met the frontline staff who were involved in the Southport incident. I haven't reproduced the Secretary of State's whole letter, but I have just picked out one particularly poignant sentence from within that. That was something that sort of just brought it back to me, filled me with enormous and immense pride. And again, I know that Secretary of State also wrote to Alder Hey, MWL and the ambulance service to pay similar tribute. I'm going to conflate two items now and talk about the 10-year plan and our commissioning intentions together. Now, one of the things that we often experience within the NHS is a level of dissonance that exists between the point at time in which a political announcement is made and when all of the work has been done to enact and implement the consequences of that. But secondly, also the dissonance that exists between the things that we are told about the public finances and what that will mean to us within the NHS. Now, it is a really good thing that the pay disputes have been settled and that we don't go into this winter facing more industrial action, but it is also the case that people out there believe that the Chancellor, when she made her statement, was raising taxes to pay for the NHS. Well, that is absolutely true, but actually the prospects as we go into next year, we are being told, will be slightly more austere than the last 2 years. So really, really important that actually that investment has gone in to stabilise the pay situation. The NHS, of course, like everybody else, will face a significant cost consequence of the added employers' NI. Again, we expect that to be in our funding settlement from the government. But what we know is, in reality, there will be little extra money for service development in the coming year. Now, that will continue to give us a significant challenge around efficiency and productivity and cost containment. But again, I ask people to sort of cast their mind back to certainly a previous Labour government, and we know that a previous Labour government invested heavily in the NHS. But when we look back to kind of that time that Blair, Prime Minister, Brown as the Chancellor, it was the third and the fourth year of the Parliament where significant growth money started to come to the NHS. So we have this kind of dissonance also with the work around the 10-year plan. The 10-year plan will be published in, I think, May of next year, and the 10-year plan will set out those 3 shifts, and in particular they will set out a lot of information about how the government foresee a neighbourhood health model, how investing, outside of hospital will reduce the demand on hospitals. And the thing for us then is to kind of work with the dissonance that exists between people thinking that there will be money to invest immediately and actually recognising that there is a period of time for us to get the design right and our planning right. So we will kick off imminently 2 pieces of work. And the first, because you hear people talk very significantly about investment in community services, we will do a comprehensive piece of mapping of the community services that we have currently got and start to identify some of the differences that exist. Now, it is not a bad thing that those differences exist. It is a product of the system under which the NHS has operated, I would say since 2012, but possibly before. And what you will see is that decisions were made within different CCGs at the time that led to different service models. Now, in some places, it is right that there is a different service model because that different service model is pointed very, very deliberately at a need of a population that is different to another population. But I will give you one example, and I know there's 1 or 2 of my colleagues who are irritated by the example that I keep using, but if you are in East Cheshire, despite having the same community services provider, despite having the same body that kind of designed and commissioned services in the past, you can be discharged from Leighton Hospital to a community intravenous antibiotic service to minimise your hospital stay, but you can't currently be discharged from Macclesfield Hospital for that same service line. But despite the historic funding levels being the same, locally decisions were made to prioritise some other service development. So as we think about what a neighbourhood healthcare model might look like in the future, we need to do quite a lot of mapping, understanding what's there today, and also, I say to you, managing people's expectations, because the answer cannot be we are going to simply level up to the best, because the resources may not be there to do that. The fact that in Macclesfield you don't have access to community IV antibiotics on discharge from hospital, there will be some other service that was there and commissioned. There are other examples. I don't just want to make this a Cheshire thing, but for instance, there are some community lymphedema services that are commissioned on the Wirral, but they aren't commissioned in other parts of Merseyside. So we will do a rapid piece of work over the next 3 months or so to make sure that we have systematically mapped out the community services and started to discover and think about what good community services will look like. The second issue that I think is really important about making ourselves 10-year plan ready is to think about what a neighbourhood model of healthcare will mean and it will look like. Now, one of the first things that we know is our local authorities will identify neighbourhoods in very specific geographic basis. Sometimes we call them the electoral wards, sometimes we call them local authority super output areas, but actually the NHS may have defined neighbourhoods in a slightly different way. And again, if you look at some parts of our patch, the neighbourhoods that local authorities recognise and want to work with, and the neighbourhoods that our GPs in primary care want to work with are very, very similar indeed. They will never be perfect boundaries because our local authorities are responsible for a resident population, and of course our GPs are responsible for a registered population, and so there'll always be slightly fuzzy boundaries, but we will do a piece of work to try and understand where the dissonance is between those two things, so we can start to think about, again, how we make ourselves 10-year plan ready. The other thing that will be quite important there is starting to try and map some of the community assets that exist. The the assets that exist in the voluntary sector, because if we're going to try and rebuild part of the health service from the bottom up, it is really important that we think about everything that we have in that space. That's why I talk about us being in a position to issue our commissioning intentions looking forward. We have a joint forward plan, but the joint forward plan kind of looks into the future. We will need to break that down into shorter chunks. Now, we haven't been told what our allocation will be for next year. We probably expect to be told that before Christmas, but again, we have gone out to all of the NHS providers and we've outlined to them, consistent with our joint forward plan, what we think commissioning intentions will look like for next year, so organisations can do their own planning. But again, the message within that is, if there is any growth monies, and actually we're trying to not raise expectations at this point in time, then we should be focusing that growth money away from hospitals, but making sure that we focus it in areas that will change the pressure that exists on our hospitals. So we'll keep you posted on that. Substantial update in January, and again, I expect probably the week before Christmas to get some notification from the Department of Health about precisely what our allocation will be for next year, and an understanding of the consequences of that. There's also within my report this time quite a lot of information and some positive stories that come from the Cancer Alliance. Now, we hear already this morning the description that our urgent care systems are under pressure, but I think what we have to remind ourselves is every day within the NHS, we have frontline staff supported by managers and others who are doing some quite amazing and remarkable things to make the NHS that we all believe in so much better. And actually highlighting some of the achievements around cancer services. And the particular one for me that I like within there is the lung health check programme. In some of our most deprived communities that has reached out, that has helped to identify cancers at a much earlier stage. And if we look at our graph and our trajectory, 4 or 5 years ago, we were significantly below the England average for the early detection of cancer. Actually, that work and a number of other initiatives has now taken us to actually above the English average for the early detection of cancer. And I want to pay tribute to all the people who work in that field, because whatever problems that we have, whatever the priorities are of the day, the thing for me, that early detection of cancer, that early treatment of cancer, the outcomes that changes, the lives that changes, is something that should never be underestimated and should be something that always exists as our kind of call to arms and focus of where we want to better the services we offer. Right, Simon, would you say a few words about Right Care, Right Person, please?
Yes, thanks, Graham. So Right Care, Right Person is a national initiative designed to ensure that people of all ages who have health and social care needs, but principally mental health needs, receive the right support. It's a police-led initiative by Cheshire Constabulary and Merseyside Police in terms of our patch. And both Cheshire Constabulary and Merseyside Police have established strategic and tactical groups that help us implement this gradually, and people would probably view it very much as a continuous improvement methodology, where they're very much doing plan, do, study, act cycles as they roll each stage out. And our 3 mental health providers, Merseycare, Alder Hey, Cheshire Rural Partnership, are engaged in that work. It's being handled extremely carefully, extremely methodically, and lots of learning as we go in terms of understanding the impact. So both organisations have worked really closely with us as the NHS, with the local authority partners, and particularly because local authorities provide advanced mental health practitioners who are able to support the sectioning of a person in the community and the subsequent conveyance to a health-based place of safety if needed. But also the voluntary community, faith and social enterprise, who are increasingly important in providing crisis responses and supporting our community services. Phase 1 concerned a new approach to concern for welfare calls. Both Merseyside Police and Cheshire Constabulary have that in place now and have been evaluating impact and regularly reporting that to our strategic groups. Phase 2 has gone live in Cheshire already and goes live in Merseyside this week, and that addresses where an individual has walked out of a healthcare facility, and there's two types of walkout. There's either somebody who's absent without leave, so it's effectively somebody who's a detained patient and usually in a mental health facility, or somebody who's absconded, so they're not detained, they're possibly in an ED department, they're awaiting treatment, and they have left that department. So again, learning from phase 2 about how we respond to that. Phase 3, and we've had guidance in the last couple of weeks from NHS England around our response to phase 1, phase 2, which, as I said, we're already implementing, and indeed phase 3. That's the element that's going to be particularly important for us as a system, as this pertains to the powers of the police to enter a property under Section 135 of the Mental Health Act and convey to a health-based place safety under Section 136 of the Mental Health Act. And in terms of health-based places of safety, the proposed Mental Health Act is going to reduce places of safety in terms of taking police cells out of that equation. But in Cheshire and Merseyside, we don't use police cells as health-based places of safety, so it shouldn't have an impact. There is a significant amount of activity underway through the Crisis Oversight Programme, which connects the police, local authorities and the provider trusts, looking at how we can improve our observational support, the availability of health-based places of safety, but actually get further upstream to prevent the need for conveyance. And that means that we're working with the police, both police forces, to make sure that officers are trained and retrained around Section 136. They're aware of the alternative services that are around for them, and also particularly in terms of the work that Cheshire are currently doing. They're currently looking at working with our hospital colleagues about improving the handover forms, because there's an aspiration under the right care, right person that people will be handed over to an ED or a health place base of safety within an hour, and that's called the Webley handover. Now, we acknowledge that emergency departments are not best placed to receive such people, and we have good provision in the north of our patch in terms of dedicated health-based places of safety, Section 136 suites. Our long-term and indeed probably medium-term goal with the availability of appropriate capital would be to provide similar facilities in Cheshire and Wirral where we don't have that. However, if we align this to things like we've got on the paper later, intensive and assertive support, improved community services and improved crisis response generally, we want to work with the police to mitigate the need to convey to a health-based place of safety and to manage people in their own homes for as far as is possible. So I think we need to commend both Cheshire Constabulary and Merseyside Police for the partnership work and the collaboration they've put into place for this, and the fact that they're actually proceeding carefully as well as at pace.
Okay. Simon, thank you very much. And this just isn't, as Simon says, an axis between the NHS and the police. Our social service colleagues are right at the heart of this as well. And then just finally, to conclude the Chief Exec's report, I wanted John just to tell people about what's been happening at Arrow Park and what's being done about it.
Okay, thanks, Graham. So colleagues will have seen in the news, no doubt, the headlines around a cyber attack that's impacted Wirral Acute Hospital. It's still a live incident, and it's being managed through national cyber leadership very well, I have to say. But until we've got a definitive root cause, that the details of the vulnerability and the tool or the malware is not being shared, because they're still working through the forensics on that. Just in terms of a timeline and some positives, if you can ever find positives in these scenarios. The suspicious activity was spotted last Monday, spotted early by the digital team in the Trust through some of their monitoring equipment. They immediately contacted the National Cyber Security team, who provided immediate advice, and they managed to isolate the impacted machines very quickly. Proactive decisions taken to take clinical systems offline. So the main EPR was taken offline but wasn't affected. That was precautionary to prevent horizontal sort of infection, and I think was a very sensible approach. So the incident's been managed throughout the week by the national cyber security colleagues and their forensic partners, and there's grounds for optimism that systems will be restored very soon. There'll be a staged return because there's a backlog of records captured on paper that need to be re-entered into the systems. I think the wider system dependencies are an interesting part of this. We'd been working for some months on a single cyber incident response plan, working in partnership with our EPRR colleagues. We developed a new plan, and coincidentally, as a system, had tested that last week in a full-day dress rehearsal. We didn't expect to put it into action quite so soon, but I'm pleased to say that worked really well. We stood up a digital command cell alongside the EPRR cell. Comms worked really well, and I think the plan's had its first test and passed, I think. All this, I think, the last thing I would say, it just signals the importance around ongoing investment around protection, but also equal focus on recovery. The threat just grows and grows, and we will never keep pace fully with emerging threats. So our recovery and disaster recovery in BCP is just as important. And I think both the trust and the system have come through fairly well in terms of scrutiny around that.
Okay. Thank you, John. And you were doing so well until you used the three-letter acronym. Business Continuity Plans is what BCP stands for. Thank you, John.
Thank you. Any questions again? Neil?
Could I just ask on that, John? I know some time ago, 6 months ago, you came and presented to the audit chairs providers to explain and outline the cyber security strategy, and there was a lot of work to do in that. I think it would be useful if we could have a report on the learnings from Wirral, which might be confidential, but where we're up to in terms of our cyber strategy for the whole system. Because there was a lot of commitments and a lot of work, and just an update on progress would be helpful.
Absolutely. I think that'd be really helpful, actually.
Thank you. Any other questions? I've just got a couple. Sorry, Warren, go on.
On the chief exec's update, I just wanted to say, I don't do this very often, I'm not very good at it, it's saying thank you. So I think, thank you very much, Graham, for all the attendance that you've done and presence at community and voluntary sector meetings. I know it's in the report, but you didn't flag it up. I know Claire Watson's been out and about as well. Really appreciate that out there. Thank you very much to Chris and Claire. Thank you for all you've done. I think I'm nearly 8 years into something like this structure. So, and Chris has been a fantastic part of everything that we've been doing over the years, including some big pieces of work around carers. So it's as a consequence of Chris's work that, you know, we saw the video earlier, but that we as a system are committed to a carers charter. So it'd be good to see within the health and work programme that's being developed, how we think through the economic opportunities for people who have been young carers, because even if you're a young carer, it never leaves you and it affects your economic opportunities throughout life. So it'd be great if we could build that into that. I'd like to thank people for, I think we're on the 4th mention of the voluntary sector at today's meeting. I think the emphasis in the NHS paper around health neighbourhoods and how us as an integrated care board can think through integrated working is fantastic. So thank you for that, Graham. We've been working on caring neighbourhoods and what that might mean as a building block with Naomi and the primary care and PCNs across the system. So it'd be great to feed that in. Just on the right person, right care. It's opening up dangers and risks for a wider workforce that we've not seen before. So it'd be great if somewhere we can begin to think about risk assessments and broader training for the people who will be facing those dangers as police are stepping back from some of those potential incidences. So thank you very much, everyone.
Thanks, Warren. Andrew?
Thanks, Graham, for really comprehensive written and sort of verbal update as well. Just a couple of points. I think just to reinforce your point about the importance of definition of neighbourhoods. If we're going to move towards truly neighbourhood NHS, that sort of integration of the concept of community with local government is absolutely critical. So in taking that work forward, I would just urge that it's always done in partnership with local government, all of whom have had to come up with their own solutions for how neighbourhood working is properly enacted. So in Liverpool, for example, we've only just recently developed our neighbourhood model and done so very much in partnership with other public services, so that we try and unify where we can that single approach to what it means to be a community and how community services are best delivered. As you say, it's not about lines on maps, but often it requires a degree of conformity in order to be able to provide that sort of joined up service that we're always aspiring to deliver. Just a couple of other points. Just on the care right person, I should say I've started that process with a quite high degree of anxiety, actually, because as you say, there are very big implications for social care services and for other mental health and community health services in terms of the way that the police might withdraw from some of the support that was previously provided. But I just think it has gone remarkably well, and I've heard nothing but praise for both the frontline practitioners who've helped to make this work, but also specifically in our region, Merseyside Police, who've taken a particularly active role to making sure this lands effectively and doesn't create undue pressures elsewhere on the system. So I think from certainly, it's only part way through, as you say, Simon, but I think so far that has been something that has been a bit of an exemplar of good practice and partnership working across the region. I think in that spirit, Graham Raj, just to draw your attention, as I know you'll be aware of, the government's new announcements about health and work that were published yesterday. This is a really great opportunity, I think, for again, joined up public services to support those that are on the margins of the labour market, that would want to work with additional support, but either because of physical or mental health barriers are finding it difficult to access employment. And there's some really quite radical proposals coming forward from central government now about the integration of support services between health, Department for Work and Pensions, local government and the voluntary and community sector to be able to make a real difference and drive the employment rate nationally up to 80%. We're not at the forefront of that, I should say, and actually, probably disappointingly, the Liverpool City region wasn't amongst the areas that was identified as pathfinders. That's partly, I think, a tribute to work done in Yorkshire, particularly South Yorkshire, who've really pioneered this work. But I would want us to be at the forefront of actions, given the large number of our citizens who are in that position of being excluded from the labour market. And I would encourage some joint work, particularly between the ICS and the combined authority in the Liverpool City region, to be able to make the most of that opportunity.
Chair, if you don't mind, I'm going to ask Claire just to comment on the neighbourhood point, and then I'm going to ask Rowan to comment on the health and work point.
Okay, thank you. I was just going to say, I think, just on the health and work, I think, Andrew, Liverpool Combined Authority are a trailblazer for the youth. Okay, but that's good news that we can learn from, I think, across the wider ICB. But in terms of the neighbourhoods, just to assure you, the ICB is not going to impose boundaries and lines across Cheshire and Merseyside. So I think, as Graham said, we'll do an initial mapping piece to understand local authority, providers, and also the PCNs to look at coterminosity and opportunities for how we currently work and how we may want to change things or work differently in the future. Absolutely, in terms of the community services piece, that's about a consistent NHS community services offer. It's not about imposing anything around the wraparound services that absolutely are critical for this, and I think Warren's piece is important too. So it's just that assurance that this isn't an ICB, thou must work this way, but very much everything in this arena we'll do in partnership, Andrew and colleagues, and we'll bring that back alongside quite a few other pieces in January around this. Thank you.
Thank you. And regarding health and work, I'm sure colleagues are aware there's quite a clear narrative that's been coming from our new Secretary of State for Health around what this really means and what opportunities there are to improve the health of those working, those who end up stepping away from work because of health problems, and what should be done to tackle some of that. Because we have such rich data and indeed rich health intelligence here in Cheshire and Merseyside, I have been approached by colleagues at the centre to see how we could potentially work together to understand the reality of the situation that is out there. And I choose that carefully because we would need to work within carefully designed parameters within something called the secure data environment, that data is really carefully managed and governed, to ask some important questions about what do we understand, what can we learn about the reality of the impacts of health, people who might lose jobs, people who might end up with escalating benefits as a result, and indeed I've got a particular interest in what might be happening to people who are unpaid carers. Because if we've got someone on the waiting list who is main carer for a husband or loved one who ends up completely losing their independence and maybe going into a care home for want of intervention, I would argue that is perhaps not the best use of health and social care resource. So I'm really keen that we start to better understand this. There's then a really vital conversation with our citizens and our public about how those data could and should work together to improve outcomes, to add real benefit to people. This idea of that we might add years to people's lives, I think vital that we are adding life to those years. And I think the arena of people working is a vital place to understand and then consider what we might do differently. But that's an important journey to go on with our communities as well. Thank you.
Thanks, Rowan. Got Steve and then Ruth.
Well, first, welcome the decision to pause the review of the local operating model work in the 9 places in the context of the letter that's in Appendix A about the new operating model for ICBs and the fact we'll be developing a new strategic commissioning framework. So look forward to that. I think it's important we take into account the roles of local authorities around social care and the roles of health and wellbeing boards as we develop that strategic commissioning plan. And to thank you, Claire, for all the good work you've done at a local level, because we really want to try and maintain priority of place for decisions around investment within the context of the overall commissioning framework the ICB will have for the future. Thank you.
Thanks, Steve. Ruth?
A completely different subject. Two quick points. I was really interested in the example on the medical physicist being deployed around Cheshire and Merseyside to improve the use of scanning equipment, the MRI scans. It's a really interesting, I don't know how much it cost, but in terms of impact, it seems to have really increased usage of the equipment. My question was, is this something which could actually support productivity improvements, and are you systematically thinking about other types of equipment? Are there other opportunities like this? Is it being embedded as a way, or is this a sort of unique piece of work just around that particular scanning? And my second question was the staff vaccination uptake. I don't know what date that snapshot was taken, but as funding has been offered by NHS England, are we seeing any improvements, and is there a wide range across the different organisations, and are there lessons being learned across the patch? They're my 2 questions, but thank you otherwise for a very comprehensive
Thanks,
report.
Ruth. Graham's up for you to answer.
So very, very briefly, we use the Chief Executive's report to gather up some things that we should celebrate. The work that our Cancer Alliance does is absolutely wonderful. And it is that balance between, isn't it, that sometimes you get somebody who's like a really passionate champion for things, and we kind of attach our management capability to that to make it happen. And you are right, we have to then go back and look at how we would roll that out and how we would use that consistently and well. We have a number of programs that will do that, so we'll come back to you with more detail in the future. On the vaccination program, we have a view through a kind of national database that will tell us that. And again, we bring that to the attention of all parts of our system so that we can see absolutely the progress compared with this time last year, but also the progress of each organisation where it's within those hospitals, and we keep pushing this message. Again, at a later date, we'll just make sure that Anthony perhaps circulates something that says, you know, here's where we got to at this date, here's where we got to at this date.
Thanks, Graham. Just a further one on vaccination rates. It'd be really good and important for us to understand what remedies we're having for that staff vaccination rate, because that's a really low figure at this time of year. Just generally, it's a really low figure. And I'd also, perhaps our board would like to understand.
I can't hear Raj, sorry.
I'd also, and I'm sure the board would like to understand for our populations the vaccination rates for COVID and flu broken down by area, so we can just see what our success or not is in those areas. Can I just take the opportunity to bring out something else from your report, Graham, and that's employee and team of the quarter. I was really pleased to see this initiative and see that we were now got people who were being awarded Employee of the Quarter, and that's Tim Thompson, I think, from Maria, from your team. That's fantastic to see, and hopefully we'll see a picture of him and that sort of thing. And the team of the quarter is the Dynamic Support Key Workers team. I'm not sure who leads that team. I can't hear what you're saying. Liverpool Place. Mark. So, congratulations to you and your team. Thank you. So let's move on. Chris.
Thank you, Raj. Okay, so the report provides updates on matters within the Director of Nursing portfolio, and I'm going to take the paper as read, but I would like to highlight a number of points within the report. Earlier this month, we had the opportunity to host a Children and Young People's Showcase event as part of the North West Regional NHS England Oversight Group. And that was held on the 11th of November. We chaired the event, and it was facilitated and chaired by a young person by the name of Izzy, who reflected on her experiences of health services across the period of transition between children and adult services, and how that these needed to be continue to focus on person-centred care that met the needs of young people. Izzy is part of a group of young people involved in a Voice and Influence campaign, which is hosted by our Beyond Transformation programme. And this ensures that children and young people feel included in conversations about issues that affect them. Within the report, highlights some of the areas of good practice that we showcased during the meeting, and the meeting was well received, and we received applause from NHS England colleagues for our presentation. I think it was important to note that when we hold meetings around children and young people, usually as adults chair them, so it was really pleasing to hear from Izzy, who chaired and facilitated the session really well. People will be aware that White Ribbon Day is recognised around the world on the 25th of November, which was Monday, and it's the start of 16 days of action against domestic violence and abuse. And the campaign encourages us to take action and change the behaviour and culture that leads to gender-based violence against women and young girls. The report highlights that within the ICB, we've established a culture that supports a workforce that is affected by domestic abuse, and that includes promoting sexual safety in the workplace. And this requires a grassroots approach. It involves building awareness and understanding where every employee, regardless of their position, recognises the significance of providing a safe and a compassionate environment for colleagues to work within. In November, earlier this month, the Quality and Performance Committee received a focus paper relating to the rates of healthcare associated infections within NHS providers and our wider place-based systems. And the report demonstrated the analytical differences between the delivery of trust-specific national thresholds for healthcare associated infections and benchmarked against the North West and England rates. The report indicated that 7 of our 12 NHS acute trusts have already breached their predetermined thresholds in at least one recorded healthcare associated infection at month 6. The committee, however, were assured by the work that's being led by the ICB with support from NHS England to undertake a review of the improvement work within both Liverpool University Hospitals and Wirral Place. And the committee also received an update on our progress and assurance against our antimicrobial resistance, which is we're using the NHS System Oversight Framework. And I'm sure that when Tony gives his update around the Quality and Performance Committee, he may mention some of the work that's ongoing within that piece. And the final piece I wanted to highlight, which has already been mentioned at the start in the questions from Felicity, was around urgent and emergency care. And as senior clinicians from directors of nurses and medical directors being involved in ongoing patient safety work, ensuring that we continue to embed the guidance in relation to maintaining patient safety for those experiencing long waits in non-clinical areas. And that includes the guidance that was issued in September this year and refers to those as temporary escalation spaces. So as senior clinicians, we are working together so that we can ensure that throughout the winter period and beyond, we are maintaining quality and safety and patient experience at these difficult times. So a group of us came together on Monday. We're going to continue to focus our attentions on this to ensure that we've got best practice and how we can ensure this across the system. So those were the points that I wanted to raise. I'm happy to take any questions or comments. Thank you.
Thanks, Chris. Any questions or comments? Ruth?
Thank you very much, Chris, for the comprehensive report. Sorry, I'll lean over. In January, I think we were told that the healthcare associated infection plans for improvement were being reviewed across all organisations. The data continue to be very concerning and are not showing any improvements. In terms of the assurance provided from the deep dive, two trusts now are going to have further reviews of their improvement plans. So my question is, what else are you looking for? What does the review involve? And what's the time frame for action to follow from the review? Thank you.
Thanks, Ruth. I don't think it's a further review. I think it's a quality improvement piece that we're working across the system. So we're working with a number of organisations within Cheshire and Merseyside, but we're also linking in with North West because it isn't just the figures that are showing this picture across Cheshire and Merseyside. We're also seeing that within Greater Manchester and Lancashire and South Cumbria. So it's about an improvement piece. I mean, we've not established the collaborative as yet, and at timescale I can come back to you on that, but this is the beginning of the piece of work for how we can have that quality improvement and introduce that quality improvement science with not just these two organisations but others as well.
Ruth, do you want to come back?
Can I just check then, have they not been using quality improvement methods in the organisations that have got these high rates until this point?
They are. There's a number of work streams within those two organisations, but what we wanted to do was do it across the system. So there is a number of task and finish groups within those two organisations, but we wanted to bring them together.
Thank you.
Thanks. Rowan?
Thanks. We've all got to work really hard at this. It's been fairly shocking that the UK Health Security Agency have reported that in the first quarter of this year, nationally, there's been an 18% rise in cases of C. diff across the country. So, hence, you know, we're seeing this not just as a challenge for us, but Manchester, Lancashire, South Cumbria, the borders down into Staffordshire as well. It means everybody's got to work even harder at this in really, really difficult times and situations. It's some of this that makes up Chris's work around red lines in corridors, because, you know, we are sadly having to care for patients in suboptimal environments, and it demands that people are working even harder to manage this. And always there's a tension between minimising the risk of infection or resistance with too many antibiotics, at the same time that we must respond really quickly to patients who might be showing signs of sepsis. So our clinicians are constantly working in a world of tension to get this right. It's a challenge, and it's important to see that the work that's being done out there. It's a national challenge, this. Thank you.
Louise?
It's us in this microphone, isn't it? Just on the urgent and emergency care and patient experience, and linking to that Red Lines Toolkit, corridor care, infection, all of that. So currently, as a Health Watch in Cheshire, we've most recently been to the Countess of Chester to do our A&E watch, which is over 3 days. We are starting this evening. We will be in Macclesfield over 3 days, and following we'll be in Leighton over the 3 days. Site visits to all those hospitals have taken place, and we are familiar with the corridors, temporary escalation spaces, but the corridors in the main. I suppose my question, Chris, is we have the Red Lines Toolkit. We're using it as part of our A&E watch. We're doing a survey with patients who are receiving care. If we see, it's that tension, Rowan, if we see what we believe is the Red Line Toolkit being overstepped, what are the teeth of the toolkit when we have people queuing and needing? And it's really tricky when you're going and engaging patient experience, because you're balancing staff pressures in your head and your staff morale in your head, and family members of patients is all being juggled in those conversations as well. But I guess for me the challenge would be if it is seen that those red lines are being crossed, then what do we do about that? Obviously we can escalate it to the individual hospital, but given that my colleagues and other health watchers may well be undertaking this as well, what do we do as a system for that?
Great question, Louise.
Thanks,
Chris?
Louise. We've been working closely with the Directors of Nursing to audit the usage of the Red Lines toolkits, and I know we work closely together on this. And I would ask that, you know, if on your visit this evening that you do see any breach of the Red Lines toolkit. However, you know, just it's extremely pressured at the moment, but I'd be grateful if you could get in touch with, obviously through the organisation, but if you could let us know as well. And I meet with the Director of Nursing on a regular basis to discuss how we ensure that that toolkit is implemented, and if there are any breaches, what we can do further to make sure it's fully embedded.
Thanks, Chris. And Chris and Louise, if I could ask you to systemise that in some way so we capture all that information in a good and routine way. Chris, I just wanted to thank you for highlighting the issue of domestic abuse. And outside the board, you provided me with some data that's quite shocking, really. I'm just going to take this opportunity to both personally but also on behalf of the board to put our full support behind the campaigns and the work that's seeking to reduce the risks and actuality of domestic abuse. Last year, 53,000 cases reported to the police in Cheshire and Merseyside, and 38 people whose cases are subject to domestic homicide review. People have been murdered, and it's likely that it was a domestic abuse case. 38 people, and we know from other sources that we have coming to this board the impact, or some of the impact of the domestic abuse has on people, but also our staff. Chris and I are looking to understand how we can get some more information about our staff, And when you Google domestic abuse within the NHS, there's an RCN report that says that 1 in 4 of our staff are subject to domestic abuse on a regular basis. So this is a really, really significant and important issue for us. And Chris, I'd like you to think through how do you engage this board, and how do we bring back information to this board about the progress that we're making on reducing those risk factors, and perhaps in 12 months' time we see that again?
Yeah, sure. I reached back out to the safeguarding teams and working closely with Chris and within the people team so that we can look at how we can capture that data and support it so we can bring that back.
Thanks. Just bring in Hilary.
Yeah, just a bit more on the data, Raj. I mean, the Cavell Trust, their research last year demonstrated that nurses alone, just nurses and midwives alone, we employ far more people than that, there's 14% incidence of domestic violence compared to 4.4% of the general population.
Right.
So you think about that, it's our own public health issue, about the scale of the problem. And then my other thought is, perpetrators, and I know we're talking about men here. I'd just like to thank all the men that I do work with who are great role models and etc. But, these are men who, as kids, have probably lived their lives in chaos and anger, and who've been let down by the system, the communities, people, generally. And how do we make space for them in our employment environments so they can talk, support their rehabilitation, and, in some instances, become role models for others. But congratulations, Chris, and I think, these 16 days, for me, highlight the complexity and sensitivity of this, and the cross-cultural, the cross-cutting issues, particularly, cultural issues in this. But I do think there's one, I'm trying to highlight the scale as an employer, and that's just for nurses, midwives. But secondly, the importance of the focus on perpetrators as well, who we employ.
Thanks, Hilary. Graham?
Very, very briefly, Chair. Both of our constabularies that we work with have a strategic priority of tackling violence against women and girls. And again, we have a variety of NHS staff kind of embedded in the governance structures and process and the development work they're doing. So I think we just need to make those connections, and we'll incorporate that into the feedback we bring next time as well. So thank you.
Just finally, can we make sure it's, and I think it is, Fiona, central to our women's strategy as well for the system? I think it is, Fiona. So, thank you.
It absolutely is in the women's health strategy, yeah.
Thank you. So let's move on. Claire?
Yes, thank you. So I'm going to present to you today the paper that you have in the pack, which reports on the month 6 financial position. So that is for the whole system, and that takes us to the end of September. The way that the rhythm of our committee structures and board meetings works is that we collect all the information from our providers once they close down their accounts. We consolidate those, we add them to our own financial position. We take it through our finance committee, and then the position then is reported to the board here. And that means that there's a bit of a delay between closing down, between the end of September and reporting it here to you today in November. And as a result of that, the chairman has asked me to present, and not just as a result of that, but also to give us time to have a bit more of a debate. The chairman's asked me to accompany my paper today with a couple of slides, which I'll also share, which updates on the very latest position for our system, but also enables us to have a conversation about some of the actions that we might need to take to address the gap that we currently have in our risk-adjusted forecast. So if it's okay, I will pull out the main themes for the month 6 paper, and then I'll turn to the slides, if that's okay, Chair. So, you'll see from the paper that we continue to have an adverse variance against the plan as a system. So we had a plan at the beginning of the year that we agreed with NHS England, which was a deficit of 150 million. We are at month 6 reporting a deficit of 183 million against where we thought we'd be at this point in time of deficit of 134 million. So we are almost 50 million pounds adrift at this point in the year. What that means is we have got a significant amount of work to do in the plans that we have already got in place, which do accelerate towards the end of the year on our cost improvement programmes across all organisations in the system. So I think it's probably best illustrated in the chart 1 within the pack, which shows a number of lines over the course of this year just to demonstrate the profile of our plan. So the dark blue line shows the plan that we set at the beginning of the year, which has a run rate, so the expenditure that we're incurring in the early months of the year, delivering a fairly significant deficit in the early months, but then there's a shallowing of that and then an uptick towards the end of the year where we plan to recover the position. So that's how we planned for the year to go. And that's that dark blue line. What we have then plotted against that is where we actually are in red. So you can see the red line, which has deviated from that plan. No, it's in the paper. Sorry, Felicity. Yeah, it's in the paper. I'll pull the screen on in a minute for the latest position.
Sorry, it's page 40 of the PDF pack.
Okay, so the red line is the actual position as it's tracking through each of the months to month 6. And as you can see, it's deviated from the plan. What we did in the summer was, because obviously that was very concerning very early on in the year, what we did was a considerable amount of work across our system that looked at all of the impact of the efficiency programmes that we've got in place, any further mitigations that we needed to enact, and across all 17 organisations, so that's 16 providers plus the ICB, we estimated what our current plans would get us in terms of a risk-adjusted forecast between that point and the end of the financial year. And the results of that risk-adjusted forecast are being updated on a monthly basis, but the results of it are shown in the green line on that chart. So you can see that we don't anticipate the red line trajectory to continue to be as bad as it was in those early months. We do expect there to be an upturn in our run rate, much closer to the plan that we agreed. And that's sort of been validated, if you like, by that detailed work we did over the last couple of months. But what you can see is we are still some way away from completely closing the gap. And that gap at the moment, when we were at month 6, we reported that gap to be £57 million across the whole system. And that is the point at which we need to do further work to improve and reduce that gap between now and the end of the year. Thanks, Graham. So the important thing that we are monitoring for ourselves is how are we tracking against the trajectory, first of all. So we identified a trajectory in the summer of what our current plans would get us to. At the very least, we need to be making sure that our actual, i.e. the red line, tracks against that green line, the trajectory that we recast in the summer. And you can see that it does. And in fact, actually, at month 6, it was slightly better. I can tell you that at month 7, we also tracked against that number. But what we are conscious of, though, is that we've still got this gap at the end of, by the end of the year if we don't do anything else. So the paper itself then goes on to describe more detail about how that gap and the forecast is distributed amongst all of our organisations in our system. You can see that within the providers, the gap is 32 million. For the ICB itself, the gap is 24 million, so they're the two things that make up the total figure that I've just quoted. The paper then goes on to describe where those pressures are and provides lots of analysis about what's driving that position and how we're performing against our cost improvement and efficiency programmes. But what I want to do now is just turn your attention to the presentation. I've only got 2 2 slides, I think it is, 2 or 3, to just bring you up to date, because we've had another set of data hot off the press for month 7, so that takes us to the end of October. But also, I want to give you the opportunity to have a bit more of a conversation around what we're doing about it, and where our opportunities are to close that gap further. Okay, so I don't know who's got the... I've got the remote. Thank you. Thank you. Okay, so this first chart is very busy and very colourful, and you're not expected to be able to read it in detail. I think just, if I can just walk you through from left to right, these slides will be shared afterwards, but it's just to give you a very high-level sense of what we call a bridge from where our current trajectory is to where we are expecting to be by the end of the year. So those first 2 columns on the left-hand side that are in blue and red show that, and sort of the further down the graph you go, the worse it is, because that's our deficit. So the blue and red says that doing nothing, those early months of the year, we would have had a trajectory of a significant deficit by the end of the year. And that was illustrated in that trajectory line on the chart I just described earlier. But what we do know from the work that we're doing and making sure that we're tracking very closely is all the actions that are taking place within our 16 providers and in the ICB itself to improve on that position. And those are the green lines that you can see then that start to build back up to a position closer to our plan. Lots of things within that are described in the paper as well, but just illustrated here graphically. We are going to be doing more activity on our elective recovery work towards the end of the year because we're opening up some new capacity. That will generate more income for our system. That's called ERF, Elective Recovery Fund. That's on that slide as an example, 5.9 million, which will support the position that we didn't have in the beginning of the year, but we will have in the end, towards the end of the year. We will also expect to see a greater step up of the delivery of our cost improvement programme across all our organisations towards the end of the year as those plans mature. In the very end of the year, towards the final quarter, you'll probably remember on the chart we just described, the sort of the dog leg at the very end of the financial year that shows a significant improvement in the very last month of the year. And there are a number of reasons for that. And some of those are listed on this slide. You won't be able to read them in detail, but there are a number of transactions that will only happen in month 12 within some of our provider organisations. Some sort of commercial opportunities that are being discussed in one of our providers in a very, very large value. It's a confidential issue, so I'm not going to share that too more than that now, but there are a number of things that are individual transactions that will be implemented in the final month of the year, or things where we're expecting income from our commission, from our regulators that we're only expecting really at the very end of the year. So that's why we see that big chunk on the 67 million creeping up to help the position. It's not without risk. And particularly some of those transactions, if they slip at all, they may slip into the following year, and that is a risk. What you will then see is a red block that is the result of our pay award. Now, that is not in the paper that I've shared, because that pay award, as you know, was only recently announced. That has been paid in this month, and the funding has been received from NHS England to support the cost of that pay award. The pay award is £13 million deficit, £13 million pressure over and above what we were planning for this year, and that's because the funding received for the pay award hasn't covered the full costs. We are continuing to have conversations about that with our providers to understand where the gaps are, but ultimately that is something we're going to have to now manage, and which has worsened our position. A number of other things then gets us to the gap of what is now a risk-adjusted forecast outturn of 73 million. So whereas I described before it was 60, it was 57, it's now 73. And the main movement between those two numbers is that pay award that hasn't been fully funded. But what I would say is that gap, which we're about to talk about, does rely on a lot of improvement work that is already ongoing within organisations across our system and indeed within the ICB, within our recovery programme. So there is still a lot of implementation risk that we need to be absolutely aware of and that we are tracking very regularly across our system. So just as an example, one of the things that we're doing to track improvement and to provide you as a board and our finance committee with assurance is Graham, the chief executive, chairs a weekly meeting with those organisations with highest risks to delivery, with the chief execs of those organisations coming along to present their latest week's position. So we are tracking certain things, certain variables on a weekly basis, recruitment, overtime, agency costs and so on, cost improvement programmes, and that is something we look at every Tuesday morning with the chief executives of those organisations so that we can identify mitigations where we need to. So the next slide then just talks about the risk-adjusted forecast, which I've described, the exercise that we do, and how it talks a little bit more about how that is broken down between the providers and the commissioners, i.e. the ICB. So the 74 million that I described on that previous chart, you can see there broken down into the provider risk-adjusted gap to plan is 42 million of that, with the ICB being 32 million of that. I should point out, though, as you can see on that slide, the providers have a deficit plan for the year of £212 million. Their risk-adjusted forecast at the moment is that there will be a deficit of £254 million, which is giving us the £42 million variance. The ICB set itself a very challenging plan to deliver a surplus of 62 million, which was a result of having to hold a lot of things of investments and other areas of slippage in order to support that provider position. Now, we are currently short of that surplus by 32 million, and that's why we've got a gap, but it's a gap against a surplus position. I just wanted to draw that out, because that is important when we think about next year. So I think I've described the rest of the points on this slide as I've talked through that first slide, but we obviously have got an absolute requirement to deliver the plan that we set as a system at the beginning of the financial year. And so in order to consider what we need to do further, this next slide just sort of pulls out a couple of the areas of opportunities that we're looking at. So I'll sort of pause on this slide and talk through these items individually. But just to reiterate, this is over and above the risk-adjusted forecast that I'm formally reporting, which is that the most likely scenario, given the plans we've got in place at the moment, means that we'll be 74 million away from our planned position of £150 million deficit. 13 million of that gap is a result of what we didn't know when we set the plan, which is that the pay awards would not be fully funded by 13 million. But the other 60 million is a result of departure from plan. So in terms of the providers then, there are obviously lots and lots of conversations going on every day across all of our organisations, within the organisations and across our system as to what else can we do. If there is something that we think is a firm plan, it's already in the risk-adjusted forecast. So, these are things that are not yet firm plans, which is why they're not in that risk-adjusted forecast, and they are still opportunities. So the first is some technical opportunities around thinking around how we manage our capital and revenue budgets together to think about opportunities to improve our revenue financial position if we have more capital funding available. And we're in conversations with NHS England as to whether there are opportunities for that. Potentially that could identify preliminary work, £8 million worth of improvement, which would support that gap. Secondly, We are, as you know, in phase 2 now of the intervention and investigation regime that we were mandated to enter back in the summer by our regulators, NHS England. Phase 2 is now, we are responding to all the recommendations in the early reports, and we are now putting intervention in place into 4 of our providers to provide them with additional support, to look for efficiencies and to deliver their plans, but also to look at what further can be done. We are also seeking support as part of that phase 2 process for our own continuing healthcare programme, which is already making really good progress, but to accelerate that even further, given the urgency that we need, we're bringing in some additional support there too. So, as a very high-level estimate, because this work has only just started, my number on the slide is phase 2 impact could be between 6 to 8 million, but that is not a firmed up number, and those organisations will need to help us understand what that will be when we've got further down over the next couple of weeks, as we've got that, that intervention, it becomes clearer. The third item is around, we really, I think, need to start looking within all providers around any investment that's planned between now and the end of the year. Given the financial situation, we need to review whether those investments are affordable and what the consequential impact would be of delaying them slightly into March or April next year. And obviously that would need to be, as anything in all of this, wrapped around really strong impact assessments in terms of quality and inequalities, etc. There are potentially, if there is capital available either within our system or outside our system, can we create some incentivisation for organisations that are currently expecting to deliver their plan, or even deliver something that is better than plan, to go even further within their own organisation through incentivisation. And then finally, we do this periodically anyway. It's good practice, this housekeeping around making sure that the reliabilities and deferred income that we are accounting for across all of our organisations is accurate and harmonised across the piece. On the ICB, so £32 million worth of that gap is within the ICB. Because the 2 areas of our expenditure in the ICB that is variable at this point in the year, there is very little that is variable. The majority of our spend now is tied up in contracts with either NHS providers or other providers, or it's about delivering elective recovery, which is funded separately. So even if we not that we would want to, but even if we slowed that down, it would not make any difference to our financial position. It would obviously, it would have a significant detrimental impact on our waiting list and our patients, but it wouldn't improve the position because it's being funded separately. So when you take all of that into consideration, there is basically only 2 areas of spend which we can control in year. That's continuing healthcare and prescribing. Those 2 things together are the reason we're reporting the gap we've got. I think I've made a note of the numbers. We've got a £49 million forecast overspend in continuing healthcare and mental health packages, and a £23 million overspend in prescribing. So that pressure, the £72 million there, is what's creating the gap in the ICB. We have talked here as a board about, in the Finance Committee, all the myriad of mitigations that we are playing in to support that position and that we've been working on over the last 6 months, and they total £40 million, but we've only got so far. There's still 32 million that we've not covered yet. And that's where we are. So the only way to improve the ICB position at this point in time now is to further address these 2 things over and above the recovery plans that we are already working on and assuming delivers between now and the end of the year. And that's a big assumption, and that is a big delivery ask. All the right things are happening, but there is still a risk there. So, as I say, we're looking for some additional support. Well, we've commissioned additional support in all-age continuing healthcare. We're also working with NHS England to get some external scrutiny on our prescribing expenditure as well. If all of those things play out, that would improve our position, and there's a table there that describes what that impact could be, but I really want to emphasise that these are just opportunities at this stage. But that would still leave us 50 million away from our gap, which would mean that our deficit for the year would be just under the 200 million mark as opposed to the 150 million mark that we agreed, and of which 13 million is a result of the pay award. So I'll stop there and I will open up to questions.
Thank you, Claire. That was a real clear explanation of the amount of risk and challenge that we have in our system and the limitations that we've got for recovering those challenges. So quite a few questions, a few hands. Steve, Neil, Erica. Steve first.
Claire, first of all, thanks for a very detailed explanation. I've bored on in these meetings before about differences between the way NHS accounts for its finances than the private and the public sector, and the ability to agree a deficit budget is something that's unique, I think, that I've come across. I mean, so my question is, the 150 million you mentioned that we started the year with, in the report it says it's we've received 150 million additional support, but it's repayable. Yeah?
Yes.
How is it repayable? What's the interest rate? Does it matter? And do you ever foresee a situation where we get to a sort of degree of accountancy normality, where you start a financial year with a balanced budget, as some of us have to do in local government?
Okay, thanks. Thanks, Steve, for the questions. So the first point on the deficit support, yes, you're right. We've now received the cash to offset the deficit of 150 million. So in future reports, wasn't received when we prepared the month 6 position, but in future reports you'll see that coming into the position and offsetting 150 million of our deficit, and that's much needed cash that's going out to our providers who are really struggling in some cases. But yes, you're right, there are business rules in the NHS that have existed for a long time where deficits at system level have to be repaid to NHS England. So the deficit that we reported last year will have to be repaid next year. The deficit we're reporting this year has to be repaid in 2 years' time. And there is some detail around the rules. It's repayable 2 years after the deficit occurs, but it's capped at a certain percentage of your overall turnover. So you don't pay the whole lot in one go. There is there's a tapering of that. At a future meeting, I mean, I've previously shared with Finance Committee when we set the plan for this year, how that, the profile of the repayments, but I can certainly share that with the board. So it does matter. It is something that we are going to need to address in our strategy going forward. And in answer to your question on agreeing a deficit plan, the NHS as a whole hasn't agreed a deficit plan. The NHS as a whole has agreed with Treasury a break-even plan. But there are underspends nationally that are offsetting the overspends in budgets at system level. That's why they've been able to fund the cash support for our deficit in the way they have. I think the challenge is that there is no more support now at a national level to offset any departure from plan. So the NHS, I guess, is the same in local authority in that the NHS can't set a deficit plan, but it hasn't done. But we are effectively more of a set of group organisations than local authorities are in the sense that you are all individually more statutory monitored in the way that you'll set your individual plans.
Thanks.
Yep.
Thanks, Claire. Neil?
Yeah, thanks, Claire, for that. It's very comprehensive and understanding. But I think what you're saying is at month 7, we're in a worse position than we were at month 6 in terms of looking at the outturn. And there's a lot of risks within that, which we're aware of. And I don't want to go into what the finance, because I will cover that. Just the fundamental point which you keep making in terms of we need to understand as an ICB, because an ICB will miss the plan but will hit the statutory duties. Trusts will miss the plans and the statutory duties by the looks of them. We need to understand the consequences of in-year actions on future years. And, my quest about having a 3-year business plan, which then finance can model the financial implications, because a lot of the recovery work that's happening this year, the full year effect will be next year and the year after. So we need to map that out in terms of our planning and our investments to see how, in the longer term, we can solve this solution. Because even if we hit our £150 million control, though, that's not a success. We've got that underlying problem that is going to tie our hands going forward. And the confusion at the moment for me is ministers saying that ICBs won't be responsible for performance management of trusts, but will still be responsible for the health economy and the efficiency of that health. We can't walk that away. So I suppose the question for me is in terms of next year's Commission intentions, which I support the approach. I'd like to see that mapped out over the 3 years and how that maps out with different assumptions. But what are we expecting of our provider trusts? How are they looking to solve their underlying deficits? Can they do that? Do they have a longer term plan? Do we understand that? How can we help them achieve that? But do trust boards take responsibility just for hitting the deficit control total or for their longer term sustainability and the solutions? Because a lot of the systems work I see we do is not going to resolve that level of deficit. So it's not just about boards, it's about the providers themselves and how we work with them in that longer term vision.
I'm going to suggest that we use the January board to examine a lot of what you've just said in terms of the overall financial strategy to returning to a balanced or surplus position, the controls and mechanisms that we will have in place, and also we should have planning and priorities guidance by that time, so it will enable us to look forward.
And I think two windows, one the ICB as a commissioner, and then one to provide a landscape.
And the third element was about the impact of those continued deficits in terms of future years funding. Well, let's cover that in January because we'll have more information then, if that's okay. But they're really, really important. They're the critical points. Thank you, Neil. Erica?
I would like to comment now as the chair. It seems the right time to
go
do
ahead.
it. So, personal thank you to Claire. Sorry to embarrass you, but it is a personal thank you for me for working with you. What I wanted to talk about for the Finance Committee really comes under two themes, and it follows on really nice. It really is around the grip and control. So this time in Finance Committee, what we looked at is what can we actually affect, and are we effectively doing, moving forward? So there's 3 examples to give you, and I think you started to talk about it. So an example, first of all, which is slide 98 in your performance plan, Anthony, was around workforce. So with workforce, we've got the weekly financial incident command, which you said is actually chaired by Graham. This covers substantive bank and agencies. It reports across the trust, but this is now proactively supported by all the chief people officers across all of the system. We are making progress. I think you can see from the performance report there is progress on agency. There isn't possibly enough progress or enough speed behind the bank and substantive, so there's more work to do. But that is the grip and the control that currently sits behind workforce. We talked about CHC and the importance of that budget. This is also included within the financial incident. The efficiencies that we need to make actually are in the bi-monthly recovery committee that scrutinise those efficiencies that go through to the executive. It came to board, Alison Lee herself came to present to us in September. It came to FERC in October, and it's actually due back to FERC in December, and this will be post the start of the PwC Stage 2 interventions. Final one is medicine. PwC did do their investigation of medicine, and it was decided that it was actually better left within ourselves to do the intervention. We're very clear of the pathways on the efficiencies. The challenge seems to be more around the resource. We work through, as we were saying, grip and control. We look through delivery, and we work through what quick wins could we make on that. I understand there's a paper currently with the execs regarding increased hours on resourcing so that we can actually move quicker with the medicines efficiency. The second thing I just wanted to talk about was delivery and speed. There's now laser focus on the delivery of these efficiencies. PwC Phase 2 will drive this through, and they will support us with those weekly commands. The performance of this Phase 2 has been scoped out and is very detailed, and that will come through to FERC, and that will actually start in December. So we will start seeing what progress is made on that. So those were the 2 main things really to say to you. It's what we're looking at as a finance committee is the grip and control that is in place, and the delivery and the speed. Final one for me just to highlight, and I think Claire's mentioned it as well, is the pressure on cash within our organisations. So the majority of the acute trusts are forecasting that they will need cash. Unfortunately, this means that there's a negative impact on the better payment practice out there, and you'll see that from those figures. For me, that sits within our priority number 4. What impact are we having on our local economy? And the impact we're having is we are delaying the payments out to our society. And that's it. Thank you.
Thanks, Erica. Erica's highlight report, though, is hugely important to this board, and thank you for leading it in such a good way, Erica, and emphasising both the amount of scrutiny but also about the collective effort that's going in to try and recover our financial position across the system. I'm going to, Claire, unless you, was there anything else you desperately needed to say? Okay. So I'm going to push this on and move to the integrated performance report. I notice I'm running really late, so if people want to step out for a comfort break, will you just do that, and I'm going to push us on if that's okay? Or do people want to go for a comfort break now? Let's go for a comfort break now. I can see people itching. Let's do that. Let's come back in 10 minutes.
key areas and then open it up for colleagues, recognising some of the issues have probably been covered already. You know, it would be inappropriate not to discuss UEC. It is our biggest operational and clinical challenge as we sit here right now, and this week has proved quite challenging, to say the least. A position not limited to Cheshire, not limited to just Cheshire and Merseyside, but nationwide. Although it's fair to say that certainly in certain parts of our system we have featured at the very highest level of escalation in comparator with other systems. As you can see from the paper, there has been a sharp decline in ambulance response times during October, and some of that has continued into November. It absolutely corresponds directly across to increases in bed occupancy, long waits in emergency departments, high non-criteria to reside rates, and exacerbated by infection prevention control bed closures that we're currently dealing with. I won't rehearse some of the answer earlier about additional winter monies. It is very much about us at this point in time having to focus in on our existing plan and placing a great deal of emphasis on the whole of the system pulling together to provide a very real and very visible response to what is happening right now. We know this is a period when incredibly we are trying to manage the delivery of today, and the delivery of next week and next month is a luxury that we can't really discuss during this level of peak activity. But there are some things that we are giving a very clear steer on and making some more rapid decisions around them. For instance, where our virtual ward capacity is maximised in one particular sector of provision or one particular geography of provision, we are allowing the boundaries for them to be relaxed to try and make use of that overall capacity. Because, as we say, there's no additional capacity to come online. It's about making use of what we've got. So we have moderated that approach. We are working with NWAS to avoid conveyance wherever possible and access these services, and indeed there's a pilot starting in Liverpool this week which will allow ambulance crews who are on site at the home with a patient, but where a referral has been made to a community service, to leave the patient in the comfort that that response will be provided, but there is a backup system to allow that. Again, that's an immediate effort to try and get crews back out onto the road and keep on top of ambulance response times. As we've mentioned, there are super-made events and there are campaigns, Home for Christmas events taking place as we speak right now. A real focus has to be on system governance, and I mean system governance at that locality basis. We do have a very clear way of managing our system on a daily basis with everybody dialing in routinely to meetings to talk about pressures and try and manage the load. One or two of our systems are stepping up an increased battle rhythm around that governance as a whole system that needs to take place around the plan. As Chris has mentioned, we have got the clinical cells established, but I think it's also fair to say that at the moment there is a fair degree of scrutiny coming from NHS England direct, and we're working with them to make sure that assurance process is understood by all and proves to add benefit and is not an additional layering of scrutiny of the day, really. I'm sure we'll come back to that in the questioning, but in terms of the elective, I just wanted to point out at the end of September we had 985 over 65-week waiters. It was the original operational planning intention to eliminate over 65-week waiters by the end of September, but recognising the impact of industrial action, that timescale has been slipped back to December. It's still a very ambitious target. There are over 20,000 patients waiting in excess of that waiting time nationally. We believe at this point that we may possibly land a position with about 400 patients having waited that long by the end of December. That's a position at least on par, if not in advance of other systems nationwide, comparable to our own waiting list size. But certainly CMAST and all the providers are working each and every day to try and get on top of that and develop a plan for each of those patients. That if they can't be done by December, then it's a matter of treating them as early in the new year as possible. Just by way of a quick update, following last month's board decision to accelerate the reduction of long waiting times and return to the RTT constitutional standards for children and young people, trusts have been mobilising that. But what we also took from the board was, let's have a clear understanding about whether that timeline which was a backstop of September next year, was really pushing as far as we could go. So we have been reassessing by specialty, by individual organisation, and we'll be able to fetch back in January a detailed timeline for how that will be achieved. I can already give the heads up that there are a significant number of trusts already pointing that that could be feasible by the end of March, not September. But there are more challenging areas, particularly in those more specialist areas, but we'll fetch that back in January if that's okay. I won't necessarily cover cancer. I think that the paper is self-explanatory and shows a really good position and a continued focus on faster diagnosis standards, one element of which Graham covered earlier. But just if you permit me, Charles, to do one bit of arguably housekeeping. It's a year since the board received the integrated performance report in this format. What we've been doing is receiving comments on the content, and I think the board has got used to the style and the way in which it's presented, but we recognise some of the content needs to be enhanced, and maybe some of the analytical tools that we use to use in the areas requiring improvement. So through the Quality and Performance Committee, 15 further metrics were approved this month. You will see them feature in your board report from January as part of a rolling expansion. Using SMART methodology to make sure that these targets are indeed something measurable and attainable. Those 15 new metrics, I'm sure for many of the people that have questioned that, will provide a greater inclusion of community, mental health, primary care and health inequalities and focus that we see at the moment. So I'm sure we'll discuss that in more detail next time. But I'll pause there for questions, Chair.
Thanks, Antti. I must say the involvement of this report over the months and the years has been really significant and good, and the analysis at the end of the table is really spot on. So well done, thank you. Any questions or comments? Trish, and then Ruth.
Thank you very much, Anthony, and for all the support that you give all the providers in the Cheshire and Merseyside system at this very challenging time. You mentioned the immediate actions that have been put in place around reducing ambulance delays. I'm just wondering, Anthony, do we have an understanding of whether they have been consistently adopted across Cheshire and Merseyside, and any impact to date?
I think there's probably two elements to that, Trish. I think, when we speak to our ambulance colleagues, they get understandably very focused on the delays that they experience in terms of ambulance handover. And I think some of that challenge that comes from NWAS is based upon what they see at the front door, without necessarily an understanding about the challenges that may exist beyond that, the ability to staff corridors, etc., that might be a solution. But there is a uniformity in the sense of fit to sit and things like that are experienced at the front door of the hospitals. I think what we have pushed NWAS themselves, and we've actually asked for NWAS area director to lead the improvement programme for ambulances, and we talk about ambulances in the widest sense. Ambulances in the sense of their ability to respond, not just about what happens when that ambulance arrives at the hospital. So it's the ability of crews to access alternatives to conveyance. And whilst we have a good, clear steer on the opportunity that might present to us in terms of the availability of those services, the response of those services, the capacity of those services, what we're increasingly pushing NWAS is to understand exactly how they can manage crew behaviour to ensure that they access them as the first port of call before conveyance. So we do have a programme that the outgoing CEO of NWAS was happy for his team to lead on that as a programme, and understood that there'll be a level of self-reflection. But that is the purpose of the at-scale programme, to try and develop that level playing field and level approach.
Thank you.
Ruth.
Thank you very much, Anthony, for the report, and obviously huge challenges that you're dealing with on a number of fronts. I was interested a couple of weeks ago to hear that the gynaecology waiting lists are a significant national problem. It's really positive that we've been able to pick out children and focus on them to try and bring down their particular needs in terms of waiting for care. I wondered what assessment you've done with regard to gynecology in response to that national spotlight. I noticed in the report there are real pressures in the cancer diagnosis element of performance with gynae, and also one of the trusts is reporting a particular challenge with gynae. But I wondered what wider assessment you've made and whether there's a real gender inequality that we need to be aware of.
Graham?
If you don't mind, Chair, I'm going to take that question. So the first thing, and this comes back to the point about commissioning intentions and what we're trying to achieve next year and each year thereafter. Now, we don't know what the government's specific short-term intentions are, but we know that they have made a manifesto commitment that all waiting times should be back to a certain point within the life of the first Parliament. Now, we have mapped that across all of our different waiting lists, and we know for our single biggest volume specialty, which is orthopaedics, we know with some confidence that Cheshire and Merseyside can achieve that. We have already identified gynae weights as an area of concern, and we will need to be launching a significant transformation project in this area. And Rowan and I are having a first discussion about that tomorrow morning. So probably that's something we'll come back to in a few weeks' time with some views about how we're going to tackle that. But absolutely, yes, that would be an example of an inequality, and we must be seen to address that. But the solution won't always just simply be more hospital procedures. We need to think about every possible approach to this.
Rowan?
Thank you. And just to build on that momentarily, so I was meeting with our colleagues from the Women's Health Hub yesterday, and the practical things that are making an active difference. We have colleagues from Liverpool Women's Hospital who are now going out and co-located within primary care networks to see the patients there and to train up their local clinicians. And what that means with long-acting contraceptives being implanted, that the wait for that, because of working together out in community, has moved from 45 weeks to 25 weeks. So taking different approaches, and it's interesting, isn't it, that Darcy's speaking to the need to move from hospital out into community. We're doing that, and it's making a material difference. There's lots more still to do, but I think the attitude and the approach and that entire programme of work from with the women's hubs that are being established is absolutely pointing in the right direction. We've got to watch it closely that it delivers what our women need.
Thanks, Rowan. Adam?
Thank you for the report. I think I always find this report really useful to try and understand what's an inherently complex system. I'm really looking forward to the new metrics. I think at my very first integrated care board just over 2 years ago, I was frustrated at the lack of primary care detail, and I don't think we've quite got there. So I'm not cited on what the new metrics are, but I do hope they allow the board to be better cited on primary care details, the contributions, the challenges of all primary care providers across all of the disciplines. There's a load of integrated challenges, such as things like referrals into pharmacy first service from many different areas, whether that's referrals from general practice, referrals from urgent care centres or other areas, that would help us gauge progress and engagement with some of the opportunities within the primary care access recovery plan that we perhaps haven't yet maximised. So I'm quite looking forward to that.
Thanks, Adam. Anthony, just an ask from me, it's similar to Ruth's. Could you have a look at how we could break down these numbers through an equality lens and understand what the experiences of our protected characteristics, people with protected characteristics are, see what data's rich enough to give us that view. I think we probably don't need it every month, but think about a regular site for board. Are we happy to move on? Yeah, thank you. Tony?
Thank you, Chair. Just to pick up on points of escalation, the Quality and Performance Committee looks in detail at healthcare-associated infection and antimicrobial resistance, which, by agreement, Chris has reported in a lot of detail in her report. I just want to add one point to that, which, in looking at this whole issue, we also focused on hydration and received a report that the National Hydration Project, which is a training programme for care home staff, began in 2024, has had some significant results. A 40% reduction in Sefton Place and nearly 20% in Wirral for hospital admissions for urinary tract infections. The purpose of bringing this to your attention is this is a preventative approach, reaching out to areas other than the hospital setting and people benefiting from early intervention strategies. Could I also take the board down to, although it's not an escalation, some continued work on safety that we dealt with at the October meeting. The pilot work is now complete in Halton and Warrington places to implement the learning from patient safety events as a replacement to previous reporting systems within primary care. Challenging work and very successfully done. The rollout is going to inform the next steps for improved reporting of patient safety. And added to that, the patient safety incident reporting framework, we're still moving on with the complex job of implementing this with independent providers. So again, that's successful work and it's continuing. Thank you, Chair.
Thank you, Tony. Any critical questions for Tony? Trish?
Thank you, Chair. Just to note, Tony, if I may, the work that the ICB are conducting around ensuring those people with learning disability and or autism or who are placed in residential settings on receiving high quality care. It is really, really important work and actually long-term prevents the breakdown of placements and sometimes people being admitted into hospital, etc. So just wanted to raise it as a note in terms of worthy point. It's fantastic stuff and really important, and we're seeing the benefits in our organisation. So thank you.
Thanks for raising that, Trish. Really important. So let's go to the consolidated report from the ICB Directors of Place, Laura, Simon. Just, if I could just open by saying I found this report a really significant step up on that road to having a place report that both informs the board but also influences decisions around the board. So well done on the report. Thank you.
Thank you, Chair. So Laura and I have just agreed to identify a couple of pieces each to keep the meeting flowing, and as it's a very comprehensive report, I think the first thing I want to draw attention to is continued place support around patient discharge and flow, which Anthony and others have referred to through the meeting. I think the report highlights we're not just focusing on people with physical needs but also people with mental health needs, and therefore really focusing upon how we can move people who are clinically ready for discharge in our mental health inpatient beds. And then in terms of our physical health settings, promoting the home first approach on the basis that no bed's like your own bed, and we need to get people home and into a more supportive environment as quickly as possible. This has obviously increased this week in terms of our interventions, and as Anthony said, will continue for the foreseeable future. The second area I wanted to highlight as well, given we began the presentation today with a presentation on work with young carers, and we've also referred to transition throughout the meeting, there's significant work going on across places and within places about improving the lives of and support for children and young people, particularly those with complex needs. Laura's leading some work on neurodiversity. That's starting to have an impact in terms of how we understand the issues that face us, how we're dealing with children with ADHD, who are autistic spectrum disorder, but also those who have much more complex requirements that don't necessarily have a diagnostic attached to them, and we're trying to approach this in terms of looking at how we best meet the needs of young people rather than saying they're on a pathway or meet particular criteria. We have to be much more agile in the way we respond in terms of health and care services. I'm going to hand on to Laura to highlight the areas she wishes to do.
Thanks, Simon. So just wanted to pick out, there's a common theme for the two Cheshires around a real focus on using the population health data that we've got to identify particular cohorts of patients that we can intervene more proactively with to reduce health inequalities. And that's influencing the priorities and the focus for both of those places in 25-26. And within that, linking back to the conversation we had earlier about the voluntary sector, the places are thinking at a neighbourhood level of how the wider voluntary sector can support the innovation that's required to get those communities involved in that proactive and preventative work, particularly around CVD, which is the biggest cause of mortality in Cheshire. And that links to the work in Halton, where they're looking at the use of family hubs within those neighbourhoods, particularly thinking about how partners come together to support children and young people and perinatal mental health. So a common theme around this out-of-hospital model and thinking differently about not just health and care services, but wider partners working together. And then in Sefton, just wanted to highlight the interesting work they're doing around health and care strategic approach to expanding respiratory services for all ages. And also the work that they're doing around the supported housing strategy for people with learning disabilities and autism, which links to Simon's reference around patient flow. When it comes to those with LD and mental health, patient flow out of inpatient stays is much more complicated and often is involving accommodation options that aren't easily found and sourced, and it's a much longer term commitment to find appropriate support for people to step down from our hospital inpatient stays. Thank you.
Thanks, Laura. Simon, any questions or comments from the place directors? Warren?
Thank you for the report. It's fantastic to see everything that's going on in place. Just to flag up, the Prime Minister and Lisa and Andy launched the covenant with the voluntary sector between central government and the voluntary sector. And one of the case studies at the key launch event was around family hubs and the way that the Department for Education are doing the process for co-design and co-commissioning and working very closely with voluntary sector at that detail. So it's fantastic to hear that's playing out in Halton. So thank you.
Thanks, Warren. Neil?
Yeah, it's just on page 114 and under risk identification on F8, 8 and 9 concerning finances. And I'm a little surprised to see that the scores are so low, considering I think all places apart from Knowsley are in deficit and missing plan. So those scores seem rather low to me in terms of the risks. And the mitigations include continuing care and prescribing. We know they're high risk. I just wondered if those scores are realistic.
So thank you, Neil. Work is underway with the Assistant Directors of Finance to actually look at moderating those risks. So actually, certainly from a Wirral place, I believe ours is in the correct position based upon the description of risk appetite and the percentage of your budget in terms of the risk descriptions this board has received. So we have been asked to look at that again, and our IDOFs are doing that piece of work. As I agree with you, they need to be at the higher end of the scale.
Thanks, Neil. Just bring you in a sec, Simon, Laura, when you look at your risk logs across the 9 local authority areas, in addition to the important point that Neil's made, there does seem to be a degree of inconsistency when we look at some of the priorities of the organisation. Urgent care is another one. So if we, in that review of moderation, could we bring the 9 places together and try and get that moderation into a more consistent place? Ian?
Thank you both. It was just to really recognise all the work in the health inequality space as well. It's really detailed, but most of the places in there, so thanks for bringing that to us. And the focus on using the population health management tools, so we have them available for all of our 9 places, don't we? So it's just more about what else we can be doing with our other areas that aren't essentially getting into that space, and how we can be a bit more proactive with the tools available and sharing that learning between places.
I think all places have got representatives involved in the Population Health Academy, haven't they? And I think there's certainly something about creating that network at an operational level so that it becomes business as usual, and that's certainly what we're trying to encourage within Cheshire, but I think we've just got to do that through each of our networks. So we have place director networks where we can talk to the other places about the ways that we're doing that informally, and then I think the Population Health Academy can help to kind of make sure that we're giving examples formally around how we're using it differently. But it's got to be part of every commissioning pathway planning. Yeah.
Thanks, Ian. Good offer. Good prompt. Okay, we're going to move to the committee report, and I'm going to suggest this, which is I'm just going to seek questions for each of the chairs of those committees as opposed to the chairs presenting. I'm going to go to Remuneration Committee. Any questions for Tony? No? Okay. Primary Care Committee? Questions? No. Thank you. The Women's Services, Hospital Services Committee? Thank you. Strategic Commissioning and Transformation Committee? Thank you. And finally, the HCP? Thank you. And thanks to the chairs for those comprehensive reports, and I really like the structures where you alert us to things. If I can go on to Shaping Care Together, Claire.
Thank you, thank you, Chair. So the paper includes the terms of reference for the joint committee between ourselves and Lancashire and South Cumbria ICB. The joint committee will be responsible for the consideration of the pre-consultation business case for the Shaping Care Together programme, agreeing the commencement of public consultation, and then finally decision making on the final outline business case. We approved the establishment of a joint committee at the July meeting, so these are the terms of reference to support that. Just for information, Lancashire and South Cumbria ICB signed off the terms of reference at their meeting earlier this month. So the programme obviously covers service transformation across Sefton, Formby and West Lancs, if I've got, yes, West Lancs, got that right, apologies. So the terms of reference are attached. There's a lot of work to do, and obviously the programme will follow the NHS England Major Service Change Framework, and all of that will sort of be delivered and reported on through the joint committee. Financial matters relating to the programme need to be reviewed, and that will go through the stage 2 process with NHS England, but clearly is a discussion we'll need to have locally as well. So I'm asking for approval for the terms of reference. We have 3 members, one of whom is one of our non-executive directors. He or she will either chair or be the deputy chair with the Lancashire and South Cumbria NED, and then we'll make a decision locally in terms of which of the 2 execs, but I think at the moment myself and Fiona's names are in the frame for that. Thank you.
Thank you, Claire. Firstly, the board's decision on approving the terms of reference. Can we take that? Neil?
Just a couple of questions from me. On page 171510, any financial matters related to Shaping Together will be settled before the joint committee meeting. What does that mean? I suppose my point is, are we conceding authority for this joint committee to take financial decisions? I think, for one, they sign off the full business case. Do we concede for the responsibility for the financial implications to the committee? I'd be uncomfortable with that. I would have thought they should come back to this board and heads up before you get there. Because of our financial position, we don't want to be given gifts of more problems without consciously taking a decision on that. So are we conceding responsibility for any financial implications of this?
That's what the terms of reference say, because it is a joint committee of the 2 ICBs, hence the non-executive chairing, the deputy chair and the 2 execs.
I'd be uncomfortable with that, Chair.
Okay. Graham, what's the way? It's good risk, isn't it? Good point.
you know that we've got a piece of work in play that could lead to some service changes, and those service changes relate to services that were formerly provided by Southport and Ormskirk hospitals. So they could be changes in Southport, they could be changes in Ormskirk. Now, you know, the reality is we cannot decide on a set of changes if some of those changes relate to Ormskirk. So we have to have a vehicle and a mechanism in which we can make those changes together, because wouldn't it be ridiculous if we took a report and said, yes, we approve the changes, and Lancashire took the report and said, no, we didn't. I think what's important here is that we have a mechanism in place that our 3 representatives who attend that meeting for us know that they have the full mandate and the backing of the board. And again, you know, it will not be that a proposal goes to that board where there will not have been time for us to have seen that in advance and to have considered our position and worked through the implications. So, you know, the risk you describe is technically there, but actually I am confident that this is the most effective way of conducting this piece of business, and we can mitigate that risk.
I'm still uncomfortable with that. Instead of conceding authority to a joint committee to commit us to what could be significant financial, I think this board has to have that authority, and the terms of reference for me need to be revisited to look at that.
Okay, I'm going to suggest that we look at the terms of reference to ensure that this board has that decision-making authority, and only in a really well thought out process do those people who are sat at the committee have the delegated authority then to commit to decisions in that joint committee. I think it's a good risk that we have to close. So could we look at that terms of reference?
Yes, we can. Obviously now Lancs and South Cumbria have approved, we'll have to sort of go back and revisit. But I do think there's just, we approve. We have a strategic commissioning joint committee where the 3 ICBs in the Northwest make decisions on delegated responsibility together. Ruth's currently chairing that, and then obviously a non-executive from the other 2 ICBs will chair it over the coming years. I suppose my question is, if we've agreed for a joint committee and all the rules that sit within a joint committee, I have said that we would, as an organisation, look at how we, you know, review the finances, and obviously NHS England will look at that in stage 2, and they'll want assurance from individual ICBs as well as the joint committee. But yes, if that's what the board's asking for, I'll take that back. Thank you.
Thanks, Claire. Andrew?
Thanks, Chair. Just a question, but obviously local government engagement in the ICB is important both for Lancashire and for this committee. In setting up an ICB, although I'm not it wouldn't be appropriate for either me or for Steve to be the representative from this board, whether there can be assurance about mechanisms in place to engage Sefton, Lancashire County Council and West Lancashire District Council in the work of the board, the work of the joint committee.
I think I might know the answer, but Claire, you go.
Absolutely. Yes, that's fine. I think that the local authorities are already being engaged individually, but we can provide that assurance, yeah. Okay,
so we've got, on this decision to approve, we need to see the terms of reference reflect the need to close the risk that was been articulated here around finances. So with that caveat, people happy to approve? Yeah. And then we need to look for members, 3 members from this board, including one non-exec, and that's for Graham and myself to take forward. Paul?
Could I ask, under the terms of reference, you have representatives of clinical or research networks. Could it be clinical?
Well, I can't quite hear what you're saying. Apologies.
Sorry. Under 5.9, you have representatives of clinical or research networks. Can it be and research networks? We need both.
Okay.
Yes, we can change that. I mean, there will be, I suppose, 3 members from each ICB, but there will also be attendees. Okay. So we can review that. That's fine.
Thanks, Paul. Okay. We're happy to move on. Thank you. Rowan?
Thank you, Chair. So I'm bringing a paper today, the proposal regarding our funding of gluten-free prescribing across Cheshire and Merseyside. seeking the approval of board to go out to public consultation on this matter. I begin this paper with a brief moment of full disclosure. We prescribe gluten-free products currently for patients with celiac disease, an autoimmune condition. That means they won't absorb nutrition properly because of the damage that wheat flour can do. My diagnosis of celiac disease was made at age 3 in Alderhay Hospital, not that far from where we are this morning, and indeed a significant number of members of my family are also celiac. At the moment, 8 of our 9 ICB places will prescribe gluten-free products. So amongst our 2.7 million population, 13,000 of our population are diagnosed as celiac. And amongst those, 2,300 people are currently getting prescriptions for either bread or bread mixes and flours. 99% of those people are exempt from prescription charges, which makes sense because paying £8, £9, £10 when you can go and buy these things separately in the supermarket therefore doesn't make sense. It's difficult to easily get behind what that means in terms of health inequalities because 3/4 of those exemptions are on the basis of age. So we don't necessarily get to see what the health inequalities look like for the under 18s or the over 60s. Currently our bordering ICBs and indeed 40% of ICBs across the nation have withdrawn funding from gluten-free prescribing. Currently, we are spending about £500,000 a year on those prescriptions. Unwarranted variation, colleagues will know, is a subject close to my heart. And indeed, it's interesting to note that other areas where there is intolerance, such as lactose intolerance, there is no prescriptions available for oat milks or something similar for those particular patients. So we seek approval to go to consult with our public on the issue of levelling up and taking on £130,000 additional cost pressure to that £500,000, or whether indeed we fall into harmony with those around us, given our well understood financial challenges, whereby we would similarly step away from prescribing gluten-free on prescription altogether. So that I am not seeking the board's approval to decide that. I'm seeking our approval to head out to the very necessary and important public consultation on this matter, please.
Thank you, Rowan. Any questions or comments on this? Andrew?
Thanks very much, Chair. Entirely understandable that the ICB should be consulting on this matter. I suppose I would just characterise it as much about a food poverty issue as it is about a clinical issue. So in the process of consultation, if we can ensure full engagement with, for example, food bank network within the region, because there may well be, as a consequence of this, pressure on their services which we ought to be aware of.
Yeah, thank you.
Thanks, Andrew. Great point. Any other questions? So seeking the board's approval to go to consultation on this. Thank you. Graham, constitutional updates.
Chair, when ICBs were established, we were asked to adopt a model constitution prescribed by NHS England. Since we've become an ICB, there have been frequent occasions where ICBs, where NHS England have changed the guidance. They've asked us to modify our constitution to reflect that. Virtually all of the changes that we're proposing this time round have come as requests from NHS England. We have to adopt them here, but then we have to go back to NHS England to ask them to approve changes to our constitution. There is nothing novel or contentious within this, and we just ask the board if they will approve it. If there's any specific questions, Matthew will ably assist us in responding to them.
Thanks, Ray. There's two sections, isn't it? There's a proposed amendment, and there's also a proposal to delegate to the Chief Executive the approval of minor changes. Just give us a definition of minor.
Apologies. So mine would be that nothing that would take any authority away from the board. It might be a typo issue, or it might be just confirmation of an updated act. But anything that would take a kind of delegated authority to the board away would need to come back to the board.
Okay. And I guess in any event, all amendments will come back to the board at some point in time, not for approval, but for information, if they're minor.
We'll confirm all the changes.
Yeah, okay. So, proposal, seek approval for these amendments and that delegation. Yep, thank you. Claire?
Thank you. So this is the Q2 update of the Board Assurance Framework. Just to remind Board, we have 10 principal risks, 2 critical, 4 extreme, 4 high. And you've heard from both Claire and Anthony on the 2 critical risks, respectively, the unable to meet the ICB statutory financial duties and the lack of urgent and emergency care capacity. There are 2 critical risks and obviously our 2 key organisational sort of priorities. You can see the changes since July on risks as well, and again there's a lot of detail in there, and obviously myself and other directors are the exec leads for these risks, and we report them through our respective committee structure. So very happy to answer any questions, or my colleagues, and again ably helped by Matthew if we can't answer them. Thank you.
Thanks, Claire. Any questions or comments on this? There is one that surfaced with Arrow Park, but I was going to ask it anyway. It's P11, John, which is the digital infrastructure risks. And then on page 286, you are whoever outlines the mitigations and the actions. And I think there's still some significant gaps in those mitigation actions, primarily, I guess, because of funding. At some point in time soon, I think we perhaps link with the agenda, the update you're going to do around cyber. Let's just understand that better at board level.
It's a really topical point. We had some national funding identified that's due to arrive imminently, and we just in the last week found out the revenue component of that is being withheld and it is going to wider pressures. That was the funding that was going to take forward all the actions in the programme, so we're just working out how we can manage that using our provider trust colleagues. I agree. I think we've got to have a plan B around some of how we take that forward, because the national support is sort of intermittent, I think it's fair to say.
So if you could target either January or it will be the March board. Thank you. Any other questions on this? Happy move on. Thank you. Claire.
Thank you. So Q2 of the Corporate Risk Register, 10 risks on the risk register. They're in Appendix 1, including 1 critical and 9 extreme. And so the most significant is the East Cheshire Trust Shimmy Summary Hospital Mortality Index risk. So again, happy to take any questions from board members on any of these. And I'm sure myself and colleagues can answer any questions, but in light of the pressures on the time, I just thought I'd leave it. But this is the regular update, and obviously we'll be bringing the next quarter to January's meeting. Okay. Thank you.
Questions? We're okay. And we're seeking approval for de-escalation of PC1 and the escalation of risk PC8 to... People happy to approve that?
Could I just comment on primary workforce? Mm-hmm. And it's probably a timing issue, but in the last primary care, we didn't agree that de-escalation, what we asked for is it to be reviewed across the 4 contractor groups, because it's such a different picture, and then have a look at it. But that will probably come through in January. I'm thinking this is the timing more than... Okay.
Yes, we had quite a long discussion at System Primary Care Committee about primary care risks, and Erica's absolutely right. I think there was some concern about the de-escalation, particularly with collective action and other pressures for general practice, but also for the other 3 contractor groups. So with board's agreement, we'll come back in January with that. Thank you.
So just to be clear then, Claire, are we not seeking that de-escalation at this board
No,
here?
I think it was a timing from when the meetings were and when the reports were written, so apologies for that. So we'll pick that up, and I think it's important to have that detailed conversation at System Primary Care Committee. Thank you.
Okay, so no approvals from the board otherwise. Are we happy to move on? Thank you. Claire, are you heading up primary care access recovery?
I'm just going to give you about a 1-minute introduction and hand over to colleagues who just walked in, who are our leads and have done all the work on the report and through the year. So this is an update, actually our 3rd update to the board on the GP Access Improvement Plan. We presented the first plan last November and then an update in March. This is in response to the 9th of May 2023 document recovering access to primary care. It says primary care, but it's actually general practice, and I think we just need to be clear with that. This is very much about a GP access recovery plan. An awful lot of work has taken place across our 9 places and with our GP practices and PCNs, so a huge thanks to all of general practice for everything they do. And we know it's particularly stressful and difficult at the moment. So I think, I'd like to thank all of our practitioners who are working on behalf of for our population. But I'll hand over to Chris, our Associate Director of Primary Care, and Jonathan, our Associate Medical Director for Primary Care, who can talk through the plan in more detail. Thank you very much.
Okay, so just to introduce myself, I'm Chris Lees, Associate Director of Primary Care, and I work at a system level, working with each of our 9-place primary care leads and their staff. So, as Claire mentioned, we were last here a year ago to present and you agreed, the Access Improvement Plan for the ICB. And NHS England requested that we took a plan back to the board in autumn. So in front of you is the update on the Access Improvement Plan that you saw a year ago and had an update on in March. I'll just go through the structure of the paper, and you'll see, have you read it, that colleagues across the ICB from digital, finance, population health and workforce teams all contributed to this paper. In section 2 of the paper, I've reminded the board of the aims of the original plan that you agreed, with some updates, narrative and some facts and figures. Section 3 is detailed in the 4 policy areas that the original national policy document requested that we updated in. So NHS England asked us to make sure that when we did the update, it was in those 4 areas. Now, in those 4 areas in section 3 are the key enablers of supporting the ICB to improve access. And one of the more notable ones, for example, is an investment in digital telephony, which I'm hoping Jonathan will talk about shortly when he talks about the impacts in a general practice setting. So I just wanted to highlight some of those areas. I then concluded with some next steps, which is based on the summaries that have been presented to us by places, which are contained within the appendix. And I just wanted to talk about, I know Health Watch are here, a big piece of work that we're looking forward to, which is Health Watch are undertaking a survey work with Cheshire and Merseyside patients to understand the impact of some of this work across the ICB. So probably that's one of the most important things is, has this made a difference to the patient experience, and is there a difference being noticed by our patients when accessing practice for appointments? So just to point out in Appendix 2, in the appendices you'll see the monthly report that we have to send to NHS England on the main 10 areas. That's returned to NHS England every month. And of course, you've got place updates on their place level improvement plans, and that contains a lot of the granular detail of work with particular practices and PCNs, so you're making a difference at that real place and neighbourhood level. So there's a lot of facts and figures in that paper, so I thought it would be helpful, first of all, if Jonathan brought to life some of these issues from a general practice perspective, and he's also going to talk about one of the areas NHS England asked us to highlight, which was the primary-secondary care interface. It's about reducing bureaucracy between the sectors. Is that okay, John?
Good afternoon, colleagues. So you've read the paper, you've heard from Chris, which outlines what's in there. I think there's a question about how this now feels for general practice. Interested colleagues how it feels for patients, which I think is also really important. There are more appointments now in general practice. You can see that from the paper in terms of the numbers of particularly how many same-day appointments there are, and we've increased those numbers over the past year. But there's also increased demand that's still there. We've got more workforce, but no more doctors. So the workforce has gone up, and this is the additional roles reimbursement scheme, and that's driving the increased numbers of appointments that are there for patients to access. If you want to see a GP, however, you've not got more GPs than you did before, and there's a workforce issue around that. I think some things in the recovery plan have been helpful. The push to digital telephony is important. This doesn't create you any more appointments, so when you get through, there's still no more slots to put you into, but it is making the experience for patients better. Just simple things like not having to wait in a queue, but being able to click a button that says, I'll have a call back, please, and then you can put the phone down, get about your daily business, and wait for the surgeon to call you back, is a significant thing that patients value, rather than having to be there fastest finger first and then sat there for half an hour waiting and listening to your 10th in the queue, your 9th in the queue. We've all experienced it, I'm sure. So things like that do make a difference for patients. Total digital triage, and we're seeing increasing numbers of practices that are moving to this, that I think they are finding is helping them to manage their demand. So in our practice, we moved to this in September, and we now reckon our next routine appointment is probably a week to 10 days away, which is significantly better than it was before, because we can manage that on-the-day demand and allocate people where they need to with the right clinician at the right time, which may not be on the day, it may be a more routine thing. So that's helped for us, and that helps our patients. Pharmacy first. So there are patients that now will not need to come to the GP because they can be diverted to pharmacy and be managed in that setting, which is better for the patient and takes the pressure off us as well. And there are formal ways in which we can do that in terms of referring between the sectors. Adam, I'm sure they wish to comment on the impact it may have had on pharmacists, and we know that there's an issue with pharmacies and their own industrial action, collective action that may be looming on the horizon as well. Primary secondary care interface, we've come and talked to you about this before. It's really, really important. It's part of the primary care access recovery plan in terms of the cutting bureaucracy section. And this is where we are still seeing work being passed inappropriately between primary and secondary care, and it can happen both ways. We've worked really, really hard on this in Cheshire and Merseyside. We published our consensus on the primary secondary care interface probably two years ago. And it has been nationally recognised. I'm often getting calls to speak at national conferences about this. People are stealing our work with pride, and you will find people are using it up and down the country, which is really, really encouraging. And we are ahead of the game compared to many other ICB areas who will say to me, we wish we had got consensus like yours. Can we steal it? Can we build our own based on yours? That's all really positive. We've got a toolkit as well, predominantly for trusts to use to communicate some of the important messages within the consensus. And we have primary secondary care interface groups based around our acute trusts across the whole of our ICB patch. It's still difficult though, and trying to get engagement, particularly from secondary care, it is hard. This is not always seen as a priority for our secondary care colleagues. And with the general practice collective action, I think it's becoming harder. Although, it is one way we could really help the collective action if we could fix this interface. And so I think it's really important, but we're trying to change culture and behaviours, and that is really hard work. There's myth-busting that needs to take place. I don't believe that any of our consultant colleagues in hospitals are trying to do a bad job and trying to make life difficult for our patients or for our GP colleagues. They just genuinely believe that things have to be done in a certain way, and that might not be the case. So there's a huge amount of engagement, education, myth-busting. It would be really good if we could get all of our hospital colleagues really engaged in this from a high level to push this agenda. I think things feel really tough in general practice at the moment, which is why we've got the collective action. The demand seems to be going up, and while we have increased our appointments and we've got increasing workforce, the lack of doctor increase is really being felt by GPs who are feeling very tired, very demoralised, and not always valued. And I think you need to accept that as well as part of the improvements that we've made. We're still working in a very challenging situation. Thank you.
Thank you, Jonathan. Chris, any questions or comments? Oh, exactly. I was looking at you. Just give us some, and what you heard from Jonathan and Chris there was the priority that we place on patients' experience. Are you hearing anything different coming from primary care?
Yeah, so the survey is out and travelling around Merseyside even as we speak, and Cheshire. We've had a differing ways of distributing this. I think it would be fair to say, Chris. In some cases, GPs have been very happy to put the survey out through their text messaging, and we can clearly see that there's been a larger response as a result of that. In other areas, that's a little more complex because of the cost of texting out, or even the desire of different practices to text out. So we're just trying to even some of that out. We are seeing a mixed response, but we're not seeing huge encouragement. And I know, I'm deliberately not looking at him, Jonathan would say that's what we'd expect. I'm looking at you now. And perfectly true, because when we've had this period of it being very difficult, people's expectation is that it will remain difficult, and there's that kind of response. But thereby hangs the problem, Chair, in that often we're trying to get people to discuss the appointments they themselves have tried to get, they themselves have actually got, rather than their perception. But perception is also still a strong part of this. But that does, of course, tell us that there's something we need to do more around communicating how our practices work. Hugely difficult because they all work differently with the different R's roles. So one person will say, well, I went to go and see my person, and the next person, why haven't I got one of those? So it's very complex out there. I think in pockets we are definitely seeing some improvement. I think in pockets that we're starting to see some better understanding for the position of primary care, of general practice, and the challenges that it's got. But my commitment was to give an update, a snapshot update in December to the System Primary Care Committee, and then come back with the full report for C&M in March.
Excellent. Thank you. Adam, and then Hilary.
Yeah, thank you for the report, Jonathan. Obviously, you called out some bits. I think just to note, there is some Health Watch work already occurred. We've seen Health Watches in Wirral and Warrington. They've published some information about Pharmacy First recently as part of this. Some of it is a particular focus, other is an effect on a wider view of the urgent care system. There's some really good stuff out there, which is good. The Pharmacy First data that's in the report's really positive. I think it's showing patients benefiting and actually helping the system. I think nationally the points Community Pharmacy England are making to NHS England aren't quite picked up in this. So that's around, we're not doing the best job we can around promotion to patients, and we're not always encouraging referrals at the rate that we should be. In fact, if you looked at, if we were able to have some graphs I mentioned earlier in Anthony's section around having some graphs about how the system works, you'd see referrals are on a slightly declining trend, although there's some seasonality elements to that. So that would be good to see. You did mention a collective action. I'm probably not at the point where I think we can talk too much about it. It's one trade body that have balloted their members. That's also come, that same trade body, which is the National Pharmacy Association. They've also said at the moment we're giving government a chance to respond, and I don't think it's at this meeting to comment too much on.
Thank you, Adam. Hilary?
Yeah, great report again. I remember commenting on this last time that you presented. The workforce section really interests me, particularly, and I get a picture of what's happening in terms of the trends for GP recruitment retention, but less so about other parts of the workforce. And I'm just thinking, for example, the declining GP practice nursing numbers. There's very few nurses nationally that choose general practice as a first destination career. And there's lots of research, particularly through the Royal College of Nursing and Queen's Nursing Institute, about why that is. And so I suppose I'm interested, are we really getting under the skin of what makes general practice nurses stay in general practice once they get there, because there's evidence to suggest once they're there that they stay. But how can we attract more in? And the same may be for AHPs or whatever, but it's something about really examining those conditions that will really attract more people, non-medical staff, into primary care. And one of the key conditions is if they can see a real career trajectory from, for example, nursing assistant, nursing associate, right through to GP partners, which some practice nurses are. Once you get further up, if they can see that career trajectory of the opportunities that are in there, you're likely to attract more. So just a comment and, something we could actually build on, but it's a great report. Thank you.
So I can see Jonathan nodding, unless you wanted to say something at this point.
Not really. Other than I agree. I think that's a really good point. Okay. Thank you.
Thanks, John. Thanks. Laura?
Yeah, I just wanted to highlight within this, it is referenced that for winter, some of the places with the most pressure in terms of patient flow are standing up the acute hubs, which will enable greater capacity in primary care to support the system around those people who need on-the-day care, and practices are taking quite an innovative approach to doing that collectively and thinking about the skill mix within that. So I just wanted to put my thanks out to primary care really for responding, and it's the use of the primary care system development funding that's enabled us to do that. So thank you.
Thanks, Laura. Naomi?
It was just a couple of points really. The first one was, I know you've mentioned it in the report, but I don't think it was just to highlight the difficulty that we've got within estates, within general practice at the minute. And I don't think that's just general practice, that's other contractor groups as well. But particularly within general practice, it's really frustrating when you could potentially have more clinicians, more staff, but you physically do not have the space to put them. As PCNs, we have been made to consider our kind of workplace very creatively. We have lots of people working in offices now, in almost kind of call centres, because we are having to do that, which also then reduces the amount of face-to-face appointments that we're able to offer for our patients. So it was to highlight that. The second one was with regards to the R staff and the GPs. So as Jonathan pointed out, there has been no increase in the number of GPs. So as patients, you're not able to make that choice to see the clinician that you would choose to see necessarily. We are an expensive resource, but we are an effective resource. The BMA are currently doing a piece of work on the number of, particularly around the R's roles, how many R's clinicians does a patient need to see before it's dealt with and kind of, before the case is closed, compared to when they see a GP. So if a patient sees a pharmacist, an A&P, a physio, actually could that have been dealt with in one appointment by a general practitioner? But then also with my R's colleagues are absolutely fantastic that what they do, seeing the differentiated workload, the specialty that they look at. But it's the general practitioner who is able to take a holistic look at that patient. But what that means is that because they are kind of removing in some ways the simpler problems outside of the system, it means that GPs are then left with a very complex patient workload, which just adds to the kind of the complexity and potentially to exhaustion that GPs are currently experiencing. So it was just to kind of feed it. That's the kind of the way that GPs are feeling at the minute, which is why we've gone down the route of collective action currently.
Jonathan?
Just one thing to clarify, because people may be wondering about it. So they have now allowed GPs to be employed as part of the ARS scheme, but there are significant restrictions on who you can employ and the conditions of that. So it has to be done through the ARRS, so it has to be at a PCN level, and the GPs need to be in their first 2 years of qualifying as a GP. So PCNs are wrestling with how they do that and how they find these GPs. Well, they can find them because they're there wanting employment, but how do they actually operationally employ them across the PCN in a way that it will work for the PCN and the patients within it, but also will work for somebody who is a newly qualified GP. So they're not, for example, doing a session here, a session there, a session there, a session there, which actually is very difficult to do when you've just qualified as a GP, rather giving them, maybe it would be an RI hub job, for example, but this is what you're going to do, sit there, be fully supported. So we are seeing some GPs being employed in that manner, but not all PCNs have worked out how to do that just yet.
Thanks, Jonathan.
Thank you. And does this explain, so for colleagues, I'm on page 353 of the pack, where it looks like there's been an important crossover, that you've got more joiners than leavers, which feels like an important moment, and it looks like there's 40 to 50 each quarter more joiners than leavers. So if there's any comment as to why that's changed and how do we build on that positivity. And then finally, to Hillary's point, I think we should be speaking to our universities that are training our nurses, because if Lord Darcy is saying we should be moving from hospital into community, how is the education and training of our nursing staff going to respond to that ask so that we do improve those options? And I think, seeing as we've got John Moores and Chester here in our system that are training nurses, we should be speaking directly to those universities about how we work with them. Thank you.
Thanks, Ryan. Ruth?
Thank you very much for the comprehensive report and for the really impressive work on improving access to care. It occurred to me, and listening to Naomi's comment about seeing multiple professionals, there's a link here with the commissioning community services more generally. Certainly when I've looked at these services in the past, sometimes there are multiple professionals going into people's homes, people are going between a number of people. So one of the things we need to think about in our neighbourhood models that are going to emerge is how primary care is part of that whole story, and that we understand the flow between professionals. So there's a piece of work, I think, to be done to make sure we link all that up effectively and we get the best mix of staff appropriate to the individual's needs. So I just want to link that with the comment you made earlier, Graham, about looking at the community services in the round, and this needs to link in effectively. And finally, one of the key things that I think has emerged around the importance of primary care is continuity of care, especially now that we have people with multiple chronic illnesses. So as part of the programme, it'd be helpful next time to hear about what we're doing to enable continuity of care to be enhanced. You may not be able to comment now, but perhaps something to come back to us in terms of progress as to whether people can see the same person over a period of time. Thank you.
Thanks, Ruth. Just a couple of comments from me before I hand over to Graham. One's just about the numbers, perhaps Chris's issue. Let me just get my notes right. Faster care navigation, it's at 21% as reported here. Do we have a trajectory or expectation of where we're going to be in 12 months' time?
So the table in the document is when practices in effect claim the payment under the contract for saying they've achieved it. Yeah. That lags behind the actual achievement, so they have until the end of March to achieve, but there's various reasons why they haven't claimed yet. It's a contract table. We were asked to put it in, so okay. Our expectation, and I have no other evidence from place colleagues to suggest otherwise, that by the end of March all the claims will be through. But that doesn't mean only that percentage of practices are far down their journey in that element. That's just the claiming process. We were asked by NHS England to put it in. It doesn't give the whole picture.
Understood, Chris. And just your sense about, do you think there's significant risk to getting, I guess, 100% of GP practices on this system? Is that the expectation?
No. There is a small element of overlap, which I won't go into now, with collective action and some of the elements, but what we're not hearing that that's going to stop the signing, because obviously there's a payment that comes with the claim.
Okay, thank you. And last one, just the work that Cheshire West did on digital exclusion, encouraging the use of the NHS app, brilliant stuff, I thought. Could we have that replicated in the other 8 places, if it's not already going on? Anybody know? Simon, is it going on in the Wirral?
believe so, through our digital programme we have within Wirral Place.
Okay.
There's also interesting evidence from that emerging, actually, the concept of people from poorer economic and social backgrounds not using digital. We can potentially disprove some of that. It's about how you initiate them onto the apps.
Yeah.
So buddies to get them using the app. Once they understand how to use it, people get on with it and they're away.
Great. Well, I'm looking at Graham. Let's make sure that learning's been spread across the 9 practices. Naomi, and then I'll go to Graham.
It was just to come back on Roman's comment about the number of joiners and leavers. I think we've seen over the last 12 months there's been a massive reduction in locum GPs, mainly through funding, essentially, but also with the use of colleagues like ANPs. So actually, whereas being a locum GP was a fairly attractive career choice, the locum shifts just are not available anymore. So I think that probably explains why we've seen that crossover, that more GPs are now choosing to take a salaried or a permanent role as opposed to go down the locum GP path.
Okay, thank you, Naomi. Graham.
I just wanted to respond briefly to the point that Naomi made about estates. The underlying issue is about the route to investment. And we're not clear what the future route to investment and future capital monies in primary care might or might not be. But in the meantime, there are some things that we can do to manage our relationship with NHS Property Services better. And James, who leads our estates work, is kind of on with that and facilitating that process. But the other issue is there was significant investment in primary care estates of the order of kind of 20 to 25 years ago, and there are an awful lot of lift schemes and third-party developments that will be coming to the end of their contractual lease terms, so there's going to be an awful lot of work for us to do in this space. 1 or 2 will pop up in the coming year, but probably in about 3 years' time, there will be a huge slog of work for us to have to compete here. So I have asked Claire, Watson and Mark to think about how we strengthen and lead our primary care estates capability as we move forward. I don't think it's something for us to be putting on the risk register now, but it's something for us to be cited on as a kind of a big 2-year out risk that we need to start working on immediately.
Okay, thank you, Graham. So Jonathan, Chris, really, really strong paper. It's really informative and it's enabled the board both to learn a lot, and you've heard some comments and questions and challenges around workforce, around the digitisation programme, around support for the primary care and secondary care community interface. The comments you made, Jonathan, about the complexity of that and the culture. We'll seek to understand what we can do about that. Really, really important stuff. Are you back in 12 months' time? Is that the plan?
March.
Oh, March. Okay, excellent. Thank you. Thank you again. So if we can move on to Simon.
Thank you, Chair. I've also got Claire Hayden, who's the Clinical Director for Mental Health Complex Care, who will be joining if there's any additional technical questions. I think it's unusual for us to bring plans like this to the board, but just to give the board a bit of a background, in late July we had guidance around the opportunity for us to reflect on our provision for people with severe and relapsing mental illness, and particularly the action services need to take in terms of maintaining these people in the care that they need. And also seeking assurance that do not attend was not being used as a reason for discharging vulnerable people. So we were asked to conduct a review. Guidance came out on the 26th of July. We were asked to conduct a comprehensive review by the 30th of September, which is an extremely short period of time. Guidance was set out on how that review should be conducted, but essentially also we received some assurance this was also about fact-finding to inform national policy. As those of us who have been around for some time will remember that we had assertive outreach teams about 10 years ago, and the policy direction took us somewhere else. The reason it's here today is because subsequent to the 26th of July guidance, a further letter was issued about a month later from the National Lead Claire Murdoch and the National Medical Director Dr Adrian Jones, and it basically asked us for the outcomes of these reviews, our action plans to come to public board meetings by the 31st of December, which is why it's here today. And again, the letter affirmed that further guidance would follow on what good looks like in terms of community mental health services, what safe care looked like, and what best practice looks like. Now, as I said, some 10 years ago we had these services, but we need to think about this in terms of the backdrop of the transformational change that's happened in mental health services in that time, particularly developing crisis responses and more latterly in terms of our community mental health transformation work. And it's the latter that really impacts more on intensive and assertive outreach, as that also seeks to mitigate crises. So our submission, which we've worked up with NHS providers, the Mental Health Programme Board, myself, with Claire's input and support, our mental health trusts are cited on this at board level, and we've also cross-referenced our submission with neighbouring ICBs as well, particularly when we were putting forward some of the workforce and costing data. And as the document states, there are barriers and challenges around the availability skills of our workforce, so the skill set of the workforce has changed around the availability of finance and the ability to provide extended working hours. So our plan is very much split into what we can do with minimal resource and then longer term what may need additional resource. Now in that regard, I think we know we need to do more work to inform implementation, and we may need to rely on redesign or targeting of existing resources, making better use of risk stratification to deliver the requirements of intensive and assertive community outreach. But also the cost estimates that we've put forward, whilst consistent with neighbouring ICBs, the resources are unlikely to follow, and even if the resources are there, the workforce isn't there to meet that need. So we have to be creative. But I think in doing this submission collectively across the three ICBs, it does give our national policy colleagues some food for thought. Before bringing in Claire, who may wish to add to anything I've said, our next steps are to reconvene our task and finish group on this, to continue to progress this work through our mental health programme board. We have a community mental health services work stream within that, and make sure that's aligned. So Claire, I don't know if you wish to add any more.
Hi, yeah. Only to add that we've recently, I know we noted in the paper that nationally they were collating all of the ICB's feedback and asks for support on this, and reassuringly Cheshire and Merseyside, along with Greater Manchester and Lancashire and South Cumbria, very, very consistent themes nationally, so I don't think we're an outlier in any way. I think there's a real recognition that this group of people have significant health inequalities when we're talking about that in terms of our wider strategy. And it's absolutely essential that we work as a system to meet their needs. So we know that nationally they are thinking about a support offer that includes training for specific staff, a much more clearer, some clearer guidance on the role of intensive assertive outreach and what that recommendation might look like, because there is talk of that 24/7 offer, which obviously, as Simon alludes to, has significant resource implications as well as workforce. So we are linked in nationally on that work.
Thank you, Claire and Simon. Okay. Trish?
Thank you, Chair, and thanks very much, Simon and Claire. Just to say, completely support the approach that Simon's outlined here. We have seen very welcome investment in mental health services to meet ever-increasing demand that I'm sure members are aware of. But with that, we've seen the development of numbers of teams in communities, so community mental health teams, crisis teams, first response teams, and actually the approach around transformation of those teams in terms of assertive is absolutely the right one in the first order. There will be gaps, and I think the report actually outlines them. But to go to more teams in the first instance is the wrong approach. It will create more handoffs to start with redesign and transformation of the emergency crisis approach is absolutely the right step forward. I'll bet that we'll need more people in terms of capacity, as you've mentioned, but to go to that place first is the wrong way round. This approach is completely right, and I'm completely in support of what Simon and Claire are doing.
Thanks, Trish. Ruth?
I really welcome the report, thank you. It's just a quick governance question really, just for clarity. We're asked to agree that regular updates on progress against the action plan will come via the mental health governance processes. There aren't any timescales or milestones in the action plan, so I was just wanting to be clear, how will the board know that when and how we've done the work? Just so could you just clarify for me so that we can be assured that we'll know at some point?
Simon?
I think that's a good point. That's why we need to reconvene that task and finish group. So it's been a bit of a get this over the line and then put it in front of our board, which is what we've been required to do. We then are going to reconvene and discuss what's next in terms of work, planning it out. And I think we might need to think about how we take it through one of our own, like quality committee perhaps, as a means of having board sight of the actions that have been done, and it's sitting with the mental health programme board in terms of delivery.
Okay. Claire, do you want to say comment on that?
Just to add in, so we have got already an infrastructure at a programme level around community mental health transformation. We have proposed and agreed that that will be the forum where much of the work will be done, which will then add some detail to that action plan and give some very definite timeframes. Obviously, we're working with the two main NHS provider trusts that have different configuration of services and are at different places. So, yeah, that will be done in the next month. We've got our initial meeting.
Okay, thank you. Any other questions? No, so just going to the reporters here for noting, really good, interesting report as well. If I've understood the purpose right, is it's a requirement to come to the board. You're lobbying policymakers to get a better model, the model that we're suggesting here. We're yet to allocate any resources to it, and that will go through the appropriate route. Simon, you're suggesting it reports through to the Quality Committee?
I think it would be useful to square the circle in terms of once we've done that work with a timeline, we bring it through to Quality Committee for assurance.
Okay, good, thank you. And of course, as we do want to see what by when, and Claire, you've explained how that's going to come to life. Thank you. Are you happy to move on? Yeah. Thanks, Claire. Simon, again, I think.
Yes, I was hoping Dr. Chris Pritchard would. Chris, excellent. Sorry, I didn't recognise you, Chris, off of Teams. We've only met on Teams, so that's why we've been looking at each other throughout the meeting. I know you from somewhere. So I'm pleased with that, because Chris, being the clinical lead for mental health in terms of primary care, is absolutely expert on this and does this every day. So as we know, the NHS offers a range of health checks for people with long-term conditions and diseases to support prevention, early intervention. People with severe mental illness are offered these checks as they're more likely to present with physical health conditions that impact adversely on their quality of life and length of life. And there's about a 15 to 20 year gap between mortality in terms of the general population and people with SMI. As I said, most of these checks are delivered in primary care by general practice. It's the long-term target to offer checks on the basis of don't just screen, intervene to about 75% of these people, with a 60% target for March 2025. Chris is going to work through the presentation, and then we'll pick up any issues as we go. So thank you, Chris.
Thank you, Simon. Put the presentation on.
1 second, Chris.
It's all right.
And thanks for sitting through the whole meeting.
No, it's all right. Thank you. So just some context. So obviously it's important that people with mental health problems such as psychosis, they're at increased risk of obviously dying at a younger age, sometimes 50 to 20 years compared to the general population. lots of the medications that this specific cohort has increases the risk of chronic physical conditions such as coronary heart disease, type 2 diabetes and respiratory illness. Also, there's obviously a lot of lifestyle changes and issues that impact their own sort of life in terms of smoking, obesity, and also in terms of providing that comprehensive preventive treatment and assessment to make sure any sort of physical or side effects of the medication which they receive are sort of managed correctly. So it obviously fits into the core 20+5 agenda in terms of how we address this population and make sure there isn't unwarranted variation in terms of health inequalities. So GPs are expected to hold an up-to-date SMI register across Cheshire and Merseyside. There's approximately 31,000 people on this register at the moment. There is significant variation sometimes. So one of the predominant reasons for this is that 30 or 40 years ago, an individual may have had an SMI code added on to their medical record, and that still triggers a physical health check this year. So there is specific exclusion criteria which involves a manual trawl of each individual's notes to go through the last 5 years to see whether they've had any contact with mental health services or they're prescribed any medication. If it's no to both of those, then we can exclude them. But it is a manual piece of work that has to be done initially, and that rolling cohort can be sort of excluded year on year going forward. So the 6 core physical health checks themselves, so it includes alcohol consumption, blood pressure, blood glucose, a height and weight check, checking the cholesterol, and also the smoking status. NHS England bring out sort of extra sort of things that we should be doing for this cohort, so there's 10 other checks that we should be doing, which involves looking at the medical and family history, the oral health, physical activity, any immunisation or screening programs which are relevant, any substance misuse, physical activity and medication reviews. We also have to clarify who is the best person to undertake that check for that individual. So sometimes it's primary care, sometimes it's secondary care. So individuals may sit in early intervention teams or have specific medication where they'll be best suited to get that health check done in a secondary care setting, but predominantly it should be done in primary care. So nationally published performance data, so we're obviously looking at a target of 60% of people having all these 6 health checks across 24-25 with an expected increase to have 75% for the year after. After Q1, we had some published figures that Cheshire and Merseyside as a whole is 55%, which puts us at 31 out of 42 across the system nationally. Q2 data was published on November the 21st, which was too late to submit to this paper, but we have dropped slightly from 55 to 52%, and gone down nationally again. So the national England average at the moment is 57%. Just for some context, the highest performing system is at 70% and the lowest is at 44%. At the end of Q4 last year, we did have 4 places that were above that target, but currently there's only 2. So historically, there's always been a trend that Q4 will see a significant increase in this sort of work and uptake, not only sort of the severe and endurable mental illness physical health checks, but every sort of area that falls under this. So it's an ongoing issue to try and address that and perhaps look at ways of trying to bring this forward so it's done earlier in the year, not leaving it towards the end. So some good practice examples. On the Wirral, there was a voluntary sector organisation which has been commissioned specifically to look at these individuals and ensure that all their health checks are done. So that is their prime focus, and that data feeds back into primary care. When they sort of first started, they only had 13% of people who had had all their health checks, and that improved to 64%. There are some practices that can use a multi-morbidity tool. So why is this important? So when you look at the data of patients who have SMI, we know that at least 60% of them have a long-term condition as well. So that might include hypertension, diabetes, asthma, COPD. There was one instance in an individual in Cheshire who had 12 long-term health conditions, so they were being recalled 12 times by their GP in a year. So there's obviously a significant duplication of work which is being taken under place. And the SMI health check essentially covers 80% of a long-term condition health check. So we're repeating lots of bloods, lots of appointments, lots of clinical time, and also looking at those results by clinicians as well. So it can be done where you look at it as a multi-morbidity template and a multi-morbidity tool to reduce that workload. Knowsley has put in something similar, which is a one-stop shop, which looks at all 6 checks being undertaken, and Merseyside have commissioned a service across Liverpool, Sefton and Knowsley to target those individuals who don't access GP practices historically from going to their own GP. So some of the challenges, so data flow and data quality issues mean that data is not published nationally and not fully reflective of actual performance. So from April this year, it was changed from a submission to a GP extraction system, which we have to make sure that all the codes that we're using, it goes back correctly to the national system and it's not been any significant variation. There is some unwarranted variation across place, PCN and GP practice level across Cheshire and Merseyside. There are differences in how the services are managed, but hopefully the same set standard should be there for each individual. This was sort of a retainment factor as part of the GP QOF income for 24-25, so there's no excess or incentive to have GPs do any extra work, and they won't be penalised if they don't undertake the same amount of work as last year, so they'll receive the same payment. There's also obviously a period of collective action which may reduce any appointments which might be available, and the ability to obviously commission these sort of tailored outreach health promotion services such as the voluntary organisations that we use in certain areas can be limited by the current sort of financial impact. And obviously that surge in Q4, which you mentioned before, so if we don't do that in a timely manner, those individuals, we don't have time to catch up. And obviously most important is that we're not just collecting information, but we need to intervene. So there are well-established resources out there that individuals who have high blood pressure, diabetic or asthma or any other long-term condition, we need to intervene in those individuals, not just collect the data. So what are we doing as a system? So we're reviewing the local and national data to see any anomalies and any sort of data quality issues, and we're working with the sort of BI team and the national team to make sure all our data is correct. We're targeting specific practices and different surgeries who are at the lowest performing within those place regions, and can we go in and help them in terms of any extra support. Also, there's a physical health SMI group with partners involved as a steering group, which takes place every month, and we share best practice where possible. When looking at some of the health checks that are undertaken, quite often 4 or 5 out of the 6 health checks are done, but unless we do all 6 health checks, then that activity is classed as 0. So sometimes it's just a case of highlighting those specific checks that aren't done and just doing some extra work. And then we ultimately want to look at trying to improve the sort of voluntary and third sector uptake to help us sort of work with these individuals who are hard to reach and don't engage with GPs. I'm happy to take any questions.
Thanks, Chris. Any questions? Warren?
Thank you, Chair. Thank you for the report. I'm just going to very parochially focus on one element around voluntary and community sector. I think for a long time we've kind of lived off as a sector end of year underspends. So it was really interesting to see the mention of a Q4 surge and that kind of thinking through of engagement, investment. I think as part of the piece, we're not going to have underspend like we've had in the past. That's, Steve's phrase is the magic money trees. No longer part of the conversation. I know he puts it in his own way much better than I do. But in terms of the strategic commissioning plan, I think we need to think through how we can embed VCSE engagement activity, not just for one strand of work, but as part of the approach to how we do delivery. Because without that underspend funding or something replacing it, we won't be able to do things like that. So thank you for the report. Really appreciate it.
Thanks, Warren. Ruth next, then Naomi, then Rowan.
Thank you very much. Really important area, and it's helpful to understand the situation that we're facing and the steps you're proposing to improve access to the annual check. But your comment about don't just screen, intervene really highlighted, I think, the importance of us knowing what the outcome was. There's no point going for your check if nobody did anything with any of the results, if you needed something. So what steps can you take to get us beyond just improving access to actually making it effective?
Any immediate comments on that, Chris?
Yeah, I think it'd be doing some analysis of the data in those individuals and look and do the health checks, make an improvement. We don't have that data, but I think obviously it's something we should look at going forward.
Thank you. Thanks. I think I've got Naomi next.
I really liked the report. I think, there are still lots of steps that we can take to try and improve engagement with this patient group. But it was just to highlight some of the other, I think some of the language that we use is that these patients are difficult to engage with, whereas actually it's that from patient perspective, it's that we need to change our services in order to be able to make them more accessible for these patients. They have a very different lifestyle to the one that the vast majority of us live. And actually it's how can we change our services to make them more accessible for our patients. We've got a real opportunity here for some total out-of-the-box thinking. I'm aware of a couple of PCNs who have, they've been working with the local drug and alcohol services to be able to actually go out to them, to be able to do the health checks there, working with one of the local churches at their Alcoholics Anonymous group. There's a big crossover for a lot of these patients with drug and alcohol issues, and also combining the chronic health checks into one check so that the patient isn't being recalled constantly. And as Ruth said, actually, if you see no benefit of going to these appointments, why would you continue to go year on year when they make no difference to you and all you are doing is ticking your GP's box? But then also from a GP perspective, it is very, very difficult to engage with some patients, and it doesn't matter how we change the priority system, whether we try to bring them in April or we try to bring them in February. It's just difficult to tick all those boxes. And I think it's just to acknowledge that we can, I feel like I've been a GP long enough now that I've seen it goes in cycles of how we arrange these annual reviews. And I'm talking about all chronic disease reviews here. There is always an uptick after January because that's when GP practices are desperately trying to get people in.
Thanks, Naomi. Great points. Can we just bring in Trish and then I'll come back to Owen.
Thank you, Chair. Thanks very much, Chris. And just to follow on from Naomi's point, I think what's being highlighted here is the real importance about collaboration in terms of delivery in a number of ways, and not least the fact that the support that people need who don't come into general practice for whatever reason, and how we can use the expertise to support general practice collaboratively in terms of reaching the right position with this target. I think, we have in Mental Health Trust internal processes as well for patients and in our teams and in our inpatient beds. I think this is an area that, really needs to be emphasised in neighbourhood working going forward in any specification that we get to, because the importance of physical and mental health integration here is critical. And it's one for us to think about, I think, as we go forward in that work.
Thanks, Trish. Rowan?
And perhaps finally, therefore, I think helping you and your colleagues to work smarter rather than harder. I was very struck by your comment that actually data quality is a real challenge. You've got a number of people who've got a code against them of severe mental illness, but actually aren't being prescribed anything, aren't accessing these services. So rather than you and your colleagues spending time going through those notes when in fact you should be seeing the patients that need you, why don't we turn to the tools like Cypher, where we could start to screen those with a code of severe mental illness and then cross-reference it with the most common prescriptions. And if we've got a whole group of people who are not being prescribed any of these things, let's sort out your numerator and denominator and get your time and effort focused in front of the patients that need you rather than sifting out those that don't. So I think that's something that we pick up outside of this meeting, please. Thank you.
So, Chris and Simon, an offer of a solution to one of your challenges there. So let's make that happen, and it's really good. But what I think I heard overall, first to summarise it, is that need for partnership and collaboration, voluntary sector, right across the system, and how impactful that is. The need for better planning, and use our commissioning, I guess, oomph to try and get better planning across the year, and also, of course, seeing through the eyes of the patient and the transformation that's needed around different modes of delivery for these really, I guess, vulnerable people. really important topic, really interesting. We wish we could spend more time on it, but we are limited here. Thank you. We're happy to move on. Thank you. So, meeting governance, minutes of the previous meeting. Ruth?
Record. I'm having trouble with this today. Just to put on record, I've given Matthew a correction. The wrong word was used in on page 383.
Okay.
It's just to record it.
Thank you. Any other corrections before I seek your approval for those minutes? Happy to approve. Thank you. There's the board action log there. I have flagged to Matthew that there is quite a few outstanding issues there and some tidying up at least that needs to be done on action. So if I can look to the exec to do that, please do keep it up to date. It's really important and it enables us, of course, to track what we've asked to happen from this board. So I'm going to move us to closing comments. Thank you again for the discussion debate. Thank you to all your presenters. Wrote some really, really interesting papers here. Thank you again. And I'm just going to take this opportunity to thank Chris and Claire for their contribution, their passion, their commitment, going above and beyond for helping us get to where we are now. And Chris, wishing you so much happiness for your retirement and leaving the NHS after 40 years. A long time, a long time. And Claire, wish you all the best for Manchester's gain is our loss. So we will miss you, but all the best for the future. Thank you, everybody. Right, it's 1 o'clock. I need everybody back by 1:30. Go and get something to eat. And let's get back into this room for 1:30. Thank you.